So I want to welcome everyone to our 4th annual reproductive symposium brought to you by Cavalcade Education. Cavalcade Education, for those of you who don't know, is our organization that was created by our independently owned practices, Rhinebeck Equine, Millbrook Equine, and the Equine Clinic at Oakencroft. And we did that so that we could share resources and work together to put on events like this. Additionally, we couldn't do this kind of an event without our wonderful sponsors. So I want to say thank you right off the bat to our sponsors. That's DECRA, Equilume, Merck Animal Health, NYRA, and Platinum Performance. So please take some time in between talks or during lunch to connect with some of the sponsors are here today. And if you're able to talk to them and look at their products, it would be really wonderful. So we're going to start off with Dr. Suzanne Janes and myself talking about let's get ready for breeding season.
All right, thank you guys so much for coming. Thank you, Dr. Goslin, for that introduction. Again, I'm Suzanne Janes. I'm with the Equine Clinic at Oakencroft.
One quick adjustment.
Okay.
It would be helpful if they could see it.
Oh,
which
sorry.
I forgot to do.
So basically, Dr. Goslin and I are going to just get you warmed up slowly. We don't want to overwhelm you with too much, deep thinking this early, and we'll get more complicated as the morning goes on. But we're going to talk about what you need to consider and get ready for breeding season. So I'm just going to run down, first start off with a little bit about risk tolerance and things you need to consider. A lot of you are, I'm sure, experienced breeders, and there's maybe some people in the room that are debating whether they want to do that. So we're going to talk about some risk associated with it, a little bit about mare selection and general health considerations, getting your mare cycling early, a little bit about breeding soundness exams, semen selection, and foal planning. And then I'm going to kick it over to Dr. Goslin, and she's going to talk more about getting ready for foaling and from there. So the first thing we really need to talk about is your risk tolerance. And in other words, how much do you love your mare? And that's kind of an obvious thing. You love your mare if you want to breed her and continue on her legacy, but you also have to realize that there's risk associated with breeding and with foaling. And so if you know that there's no way you would risk losing your mare, then perhaps this is not the right route for you to go. And you might want to consider embryo transfer, for example, and use your mare's embryo and put it into a recipient mare. Some of the causes of death around foaling, and even if there isn't a dystocia, even if it's a normal foaling, they can have periparturient colics. You can lose your mare to post-foaling ruptured uterine arteries. They can bleed to death. They can sustain injuries to their reproductive tract, vaginal lacerations. They can sustain a uterine prolapse post-foaling that cause death, and even fractures. So, a lot of people love their mare, but they don't consider this beforehand. So that's a major consideration. And then, you may go through all the steps of breeding your mare and all the financial commitment and the emotional commitment, and then the foal may die. You may have late-term abortion. Your foal may die during birth or shortly after. So that's something you need to consider. Do you want to take that risk? And then obviously the worst case scenario is that you lose both of them, and that would be obviously very devastating. So again, you may think about these things and say, wow, embryo transfer is really more relevant to me than I realized. The other major thing to consider is the financial commitment to breeding. And I work with a certain demographic of people who, I just got this mare and the guy down the street has a stallion, I got a uterus. wham, bam, I got a free foal out of the thing. And it's rarely that simple. So a lot of practices will have breeding packages. So say everything went absolutely perfectly. We check her on the first cycle. She's ready to go. Perfect. You're still looking at about $800 or so for breeding her on one cycle with fresh cooled semen. If you're using frozen semen, it can be around $1,400 to $1,500 for one cycle. You may do all of that, and then your mare has problems. So she develops fluid post-breeding and has endometritis, and that's an additional expense of flushing her antibiotics if she develops an infection. So there's a lot of added costs that people don't think about. Then you also have the expense of your stud fees, and then costs of missed cycles. So we could get her all the way ready to go, ready to breed, and then the semen doesn't show up. It's lost by FedEx in another state, and you've lost all of that money you've already invested getting her there. Obviously, the cost of foaling complications. If you have a dystocia, you're going to have a big vet bill associated with it. And the cost of a sick foal. So you could get all the way there, and then your foal is sick. Have you budgeted for that? So you really need to think about these things before you just say, got a uterus, got a stallion, easy peasy, because it's usually not that easy. Those are the people that just, they don't deserve it to be that easy. So as far as mare selection goes, younger is better generally. You want a mare, somewhere between 4 and 13 years would be an ideal age for breeding. You want her old enough that she's physically mature enough to carry a foal and that she is cycling normally. Once you get over that 15-year range, they are more predisposed to developing Cushing's disease, and that will reduce your fertility. So you want to, if you have a mare that you're planning to breed that's over 15, we really strongly recommend that you test her for Cushing's. If you're doing it during the breeding season, we recommend a TRH stim test. So that will get your kind of early cases of Cushing's disease. Because I have done that early in my career where I went through all the trials and tribulations of trying to get this mare bred, and it wasn't working. I'm like, maybe I should test her for Cushing's like later after we'd spent a lot of money. And sure enough, that was the case. So lesson learned, test them before, get it under control before. And fertility does decrease with age. So older mares tend to have a tighter cervix, and so they're more prone to developing post-breeding metritis. It's harder for them to clear fluid post-breeding. So for those older mares, if you have a maiden 5-year-old and a maiden 20-year-old, they do not have the same conception rate. And I think people don't realize that. So that's just something to consider if you're looking to get a mare for breeding. Start early. Is she genetically favorable? You obviously want a mare, you love her, she may or may not have any talent. I don't care about talent, but does she have good body conformation? Are her legs straight? Does she have clubbed feet? This happened like last week. I had a owner that had a new mare and she said, my friend down the road has a stallion. I think I'm going to breed her. She had a horrible club foot. She had a horrible underbite. And I said, is this really like the genetics that you want to be putting into the equine population? Just because you can doesn't mean that you should. If you have a severe case of kissing spine in your mare, that is heritable. So you don't want to pass those genes on to the next generation. And then her attitude does matter. So if you have, a lot of people have a nasty mare and they want to breed her to soften her, that may backfire, and you may now have a nasty mare and a nasty foal. So don't let that be your main reason. General health considerations, this is very obvious, but worth mentioning. You want a mare in good general health, an ideal body condition score. A lot of these overweight mares, really fat mares, have lower conception rates. If they're too thin, they're more prone to not cycling at all or having early embryonic death. Good nutrition, and one of our sponsors here, Platinum Performance, has a really good general equine supplement that's very good for developing foals and having a good healthy foal in utero. So you can chat with them about that. You want them to be obviously up to date on their vaccines, good hooves, good teeth, up to date with their deworming, and serviceably sound. They don't have to be sound, but we don't want to breed broken mares. And, just remember these brood mares, they give us a lot, so they deserve to have regular trims. They deserve to have good dental care. Just because you're renting their uterus, don't forget about the rest of their body. General, again, take home message, don't breed a broken mare. I think a lot of people have this, well, she's got laminitis, can't get much more out of her. Let's have a foal. And I mean, that's so inhumane. Of course, we wouldn't ask a mare to do that. A lot of these guys that have degenerative suspensory ligament disease, the hormones of pregnancy, once they're bred, those suspensories will drop even more. So have that in your mind. That's not a good breeding candidate. Mares with chronic lameness, they're already dealing with a lot on their body. Is it fair to put them through on their bodies? You don't obviously want to breed a mare that's in poor body condition because of underlying disease. You need to get her healthy first. And again, make sure that any metabolic disease is already dealt with before you start the process. So timing is everything. This is not meant to be an insensitive photo. I hope there are no FedEx drivers in the room. It's just an illustration of, in a perfect world, everything goes great. So in a perfect world, we get your mare cycling early in the year. It allows us to follow her first cycle, when we first meet her, gives us better predictability of how her reproductive tract is going to behave. It allows us time to treat any issues that we might find along the way. If she has an underlying infection or she's prone to developing endometritis. In a perfect world, the semen arrives right as expected, which we often, as you can tell, is not always the case. And then when it arrives, it's alive. So there's a lot of things in the perfect world, but we know that they're not all that easy. So time-wise, you want to start early. Timing is everything. Get your mare under lights early. And a lot of people say, I don't want to foal before May. It's too cold. I'm not starting until later. I'm not even going to think about it until later. Please think about it now. You want to give yourself about a year and then about a half a month or a month before the time you want your foal born. So because they are not all bred perfectly on the first day we see them, we need a little wiggle room. So it allows us to check them, follow the cycle, get them bred, and then a little bit of wiggle room. So planning wise, do start now as far as getting them under lights if you haven't already. And as far as lights go, for the thoroughbred people, if there are any here, the breeding date is, Valentine's Day, right? The holiday of love. And so I use the major holidays and start putting them under lights around Thanksgiving time. And that will allow them to be ready, theoretically well cycling by February. You want to add lights until 11 p.m. In these winter months to provide about 16 hours of continuous light per day. You can use a 200 watt incandescent bulb or 240 watt fluorescent bulbs. And then this photo is, again, one of our sponsors, Equilume, and it's a really nifty mask. I found out it was developed at my alma mater in University College Dublin in Ireland. And I guess they know about having no light there. I would like one just for my mental health. And so it shines blue light into one of the eyes. It's a mask, and it gives the horse that continuous light period. And some benefits of it, obviously the horses don't have to come in at night, so they can stay out 24 hours a day, which a lot of horses are happier staying out. And, it affects their melatonin, so it does get them cycling. Some of their studies have shown that the horses, their gestation periods for these mares that tend to go long, it's shortened a bit, and that the birth weights of their foals are a little bit bigger. So there are some other benefits. And then obviously in sport horses, it keeps their coat short for the winter months, which is nice too, if you're dealing with that. Again, not a big thing about the exam other than to say there will be one. In an ideal world, you want a horse that hasn't been a big problem. If you bought this horse for cheap and it's, they couldn't get it bred for 17 years. Don't take that challenge if you have a choice. try to get one that doesn't have pre-existing problems, of course. Good perineal conformation. So these mares, we always think about if their vulva is tipped or, if it's tipped, they're gonna, feces can go in and they can contaminate themselves. But remember too, the whole internal tract is pulled forward as well. So these guys have a lot more difficult time clearing fluid and cleaning themselves out as well. So that has somewhat to do with good body condition. If they're underweight, everything's going to be tipped, but also these older mares that have had a bunch of foals, they're going to tip as well. So try to start with good conformation. We're going to look at, a good vaginal exam, check out their cervix, make sure there's not urine pooling. We're going to obviously palpate them, ultrasound them, look at their uterus ovaries, that they're cycling normally. We're going to identify intrauterine cysts early in case they're, very large and we need to intervene. And then obviously look for free fluid, signs of infection. And then, case by case, I would say, I assume most of us would do uterine cultures and cytologies on everybody pre-breeding. Some mares require a biopsy, not everybody. And then obviously we can scope the uterus as well if that's deemed necessary. So just a little diagnostic stuff. The other thing that you need to be aware of, and as Dr. Gosselin said, we're not going to pick your stallion for you. That's not our job. But we need to at least know, what type of semen you're going to use for your mare. So is it live cover? What days is the stallion in the shed? That's important to know. Obviously, if you're using fresh cooled semen, what days do they collect? What time zone are they in? And you always run the risk of delays in shipping with fresh cooled semen. If you're using frozen semen, how many doses do you have? How many straws are in a dose? It really depends on the concentration and the volume of the semen in each straw, and they're variable. So this is information you need to know ahead of time. If you have one dose, it's a much bigger challenge for us to get the mare bred, especially if the stallion is dead and that's all you have. So this is just information that we need to know in preparation. And then finally on my side, again, before you get all of this emotional, financial investment, where will your mare foal out? Where will the foal live? You can have these foals run around, you have nowhere to put them. Will there be other horses that it's going to grow up with? Do you like young animals? They're kind of jerks sometimes. And will you train it? So we don't want a bunch of ill-behaved homebreds. So I'm going to kick it over to Dr. Gosselin and she's going to continue on. Thanks.
Okay, so now we're going to talk about the foaling part. And I have to apologize right now because I brought my soapbox with me and I'm probably going to throw it down a couple of times and climb up. So just be aware. But we're in addition to watching me climb up and down off the soapbox, we're going to talk about pre-foaling vaccines and testing for NI. We're going to talk about monitoring your mare for foaling, how to set up your foaling kit, what your emergency plan is and the importance of an emergency plan, the benefit of colostrum testing and collection, and neonatal exams and IgGs. So I think that it's really important to understand that pre-foaling vaccines are essential, right? We know that the mare creates colostrum and the colostrum is antibody rich, and it's important to put the right vaccines into the mare before she foals so that the foal, after it consumes the colostrum, gets high level of antibodies to the diseases that it's going to be exposed to. But I will tell you that not all mares are going to get the exact same pre-foaling schedule, pre-foaling vaccine schedule. Partially, it's due to where the mare is going to foal, where the mare and foal are going to travel. And then also, I think some of it is up to the veterinarian, the discretion of the veterinarian. So I will tell you, like AEP creates a list of core vaccines that you can look at. And those are the vaccines that absolutely they recommend for every single horse. In terms of pre-foaling vaccines, I would actually say if I was to create a core list of pre-foaling vaccines, I would list EHV1 or Rhino, and the trade names for those are a Prodigy or Pneumabort, as a essential pre-foaling vaccine. Those are going to be given at 5, 7, and 9 months of gestation, and it helps to protect against virus abortion in the mare. So every pregnant mare should get EHV1 or rhino vaccine at 5, 7, and 9 months of gestation. If the mare is going to foal at a farm where there are multiple foals being born, then I'm going to recommend that the mare gets vaccinated for rotavirus at 8, 9, and 10 months of gestation. Rotavirus helps to protect the foal in for situations of rotavirus caused diarrhea. So if the mare is going to foal by herself and she's going to be maybe one of two, and there's not a lot of foals that are born at this place, I would say rotavirus is not necessarily essential. But if there's a lot of risk and you want to cover your mare for everything and your foal for everything, then I'm going to recommend that we vaccinate the mare for rotavirus at 8, 9, and 10 months. Botulism. Botulism is something, again, that we vaccinate the mare for protection of the foal. So if we are going to ship our mare and foal to be bred in places where botulism is an issue, like Kentucky, then we would vaccinate our pregnant mare either annually once the mare has had an initial series, which happens at 8, 9, and 10 months of gestation, or we were going to get her on that annual cycle. So she would get that initial series. Some veterinarians like to vaccinate against leptospira, which is another form of abortion, can cause abortion. And those mares are vaccinated in the fall. And then if we are going back again to the pregnant mare core vaccines, I think every veterinarian is going to recommend Eastern, Western, and tetanus in that period of time from like 4 to 8 weeks prior to foaling. And that helps to really boost those antibodies before the mare foals so that the colostrum is rich and will provide that protection to the foal. You will have some variability in terms of what veterinarians or farm managers are going to recommend in terms of whether they do include rabies in that last pre-foaling set of vaccines, or flu rhino, West Nile, and Potomac. And there's a lot of variability in terms of when people recommend strangles and if they include those in their pre-foaling package. Another thing to consider before the mare foals is testing for NI. NI is neonatal isoerythrolysis. I knew I was going to stumble over that word. And it's basically a situation where the mare develops antibodies that she produces in her colostrum that attack the foal's antigens on its red blood cells. So the foal consumes the colostrum. It then attacks the antibodies on the red blood cells. The red blood cells lyse, and the foal develops anemia. The antibodies are basically the symptoms of NI can be pretty nonspecific, but you can see them anytime from, I read somewhere as early as 9 hours to up to 3 days later. We had a mare that foaled a couple of years ago, and when I got there for the pre-foaling or for the new foal exam, the foal was already like just totally out and was severely affected. So don't discount that as something that doesn't happen at that 8-10 hour check. Like, it is altogether possible. The symptoms can be, like I said, nonspecific. The foal can stop nursing, can just be completely out, flat. Can also, in this picture, you can see that the foal is icteric, where it has yellow mucous membranes. And you'll see that like on the gums and the eyes, and sometimes like the lips of the vulva and fillies. So it's something to be aware of. The good news is we can screen for this. And so we can do screening for foals, or we screen the mares approximately 2 weeks before their due date. And we blood type them and look for the presence of the potential presence of these antibodies. And then basically once the mare foals, then we can do a jaundice foal agglutination test. If the mare screens positive, you test the foal as soon as it is born, before it starts nursing is the idea. And then you do this JFA test where you introduce some of the colostrum with the foal's blood, and you look for clotting. So That's how that works out. Monitoring your mare. So this is where I'm going to get up on the soapbox and talk about, are you prepared to monitor your mare? I know that some people are like, oh yeah, I'm going to have a foal. I'm really excited about it. I want to see the miracle of birth, right? But there's a lot involved in the miracle of birth. First, I'm going to say that it's really important to like confirm the due date of the mare. Like sometimes you get information passed along and then you later on learn that the due date wasn't actually correct. So check the last breeding date and do the math yourself, and make sure that you're confident in terms of when that due date period is. And you also need to know to look for physical changes, and you need to know what those physical changes are going to be in the mare, right? So if you get to your due date for your mare and you're like, oh, maybe I need to figure out how things are going to change, it's a little bit too late by that point. Like, do some research leading up so that you're aware of what the physical changes are going to be, so that if your mare starts bagging up prematurely and developing an udder prematurely, you're aware of that and you see it happening, and you know, hey, that's not right, or that's appropriate for her, considering the due date. Also look at pH testing. If you're foaling one mare or two mares, there's a lot of value in pH testing. And I talked about this last year at our symposium, and I think there's probably a recording maybe of that up on cavalcadeeducation.com. But there's a lot of value to pH testing. Some people, I think, find it frustrating. But what you're looking for is you're getting a sample of the mammary secretions and you're looking for the pH to drop. And it'll drop from above 7 to usually it's like 6.4, approximately 12 hours. There is some 12 hours before foaling. There's some variability there, and especially with maidens, and you have to test more than once a day. But there are people that have used this and it's been very successful. There's also commercially available predictable kits. Again, you have to get comfortable using them and you have to test regularly so that you can see the trends. That's really what you're looking for, is trends. And then at the end of the day, someone should be there when the mare foals, right? You should have a night watch person. Or if there's not going to be a physical presence in the barn, there should be cameras that are on the mare. And then I'm always going to recommend an alarm system. This particular alarm system in the upper right corner is full alert, where you suture this. It's basically a key into the vulva. And when the mare breaks her water and the fetal membranes push through, then it pulls the pin out of the key. So there are other options, like there are monitors that are on halters and all sorts of things. But I think the more systems that you have in place, the more likely you are to catch it when the mare foals and to not have her foaling without somebody monitoring. So setting up your foaling kit. The list that I have here is mostly things that were provided by the AEP, and then I plugged in a couple of things that I felt were useful. A bucket, a tail wrap. The tail wrap can be either like something that you can wash over and over, or it can be like disposable brown gauze or vet wrap. Cotton, disposable gloves or sterile sleeves, depending on how involved you're going to be in the process. Sharp scissors, navel dip, and that can be either diluted betadine or diluted nalvasan or chlorhexidine, and a cup. And the cup, it's important to recognize that this is a dip, it's not a spray. Like, I'm not a big advocate of spraying a belly button, because I don't think it does as good of a job. Whereas I think if you're dipping the belly button, you're actually getting the tissues well coated in the dip. So we use either a shot glass, because I know you have shot glasses from all the places you've traveled to, and you're like, what do I do with this shot glass? It's an excellent option. Also, you can like cut the tip off the end of a 35cc syringe and invert it, and use that as a dip cup, where you just put the solution in it, you squirt it up onto their belly wall when you have the umbilical stump surrounded, and wiggle it around, and that does a really good job. I'm sure everybody has lots of ideas, but the important thing here is not a spray, a dip. Full enemas. I like fleet enemas. Again, I'm going to say you can give 2 enemas. Beyond 2, do not. Like, tell your veterinarian, have a conversation. And I actually really like to don't throw away your enema bottle after you use it. You put a little bit of warm soapy water in there and you can reuse that over and over. But it's really helpful so that you can reuse that enema bottle on the foal that you give the initial enema to. Umbilical clamps or tape, clean towels, a thermometer, and then again, a colostrum refractometer. I think a colostrum refractometer is an essential part in everybody's foaling kit. And I have a measuring cup in here. I know that some people can probably express a little bit of colostrum out onto the refractometer. I'm going to say put it in a cup and then put it and make sure it's a dry cup, that it doesn't have any other stuff in it. But use that and then transfer it into your refractometer so that you're not like in there and then it gets kicked and it flies across the room and then it's a broken refractometer. Headlamp, flashlight, and then I included for optional, depending on how comfortable you are and how versed you are in foaling, a pulling strap or a pulling or chains with handles, a full resuscitator. And I think maybe sometimes it's like if you buy this and put it in your kit, maybe you don't have to use it. And then I included baling twine, as I think it's really important when you tie up the fetal membranes to have some sort of string structure that you can use to tie up the fetal membranes. So I like baling twine because most of us have it. And then Banamine paste or injectable Banamine. Is there anybody here that's like, you're missing this? Because we could all benefit from that. If you have like absolutely, I have to have this in there. Nobody? Okay, brilliant. So, and that actually transitions very nicely, I think, into my next slide. But yes, they included on the AAP, they included paper and a pen as one of the things. And I think I've gotten to this place where I try not to use very much papers and pens these days because I feel like I leave stuff behind me. But your phone will work for that. So you can write down, she broke water, you write it into your phone, you know, the foal was born at this time. Then you can look back and say, oh, or a stopwatch. Some people use a stopwatch. And then absolutely, if your veterinarian's phone number is not in your phone, then you should have it like taped to the side of your foaling kit. So I totally agree with you. And this foaling kit is actually available commercially. You can purchase this handy dandy kit. I do think there's maybe a little too much in there, but it is available, I think, from ARS, and I think the price is around $250. And they have like it's like a base level, and then they have like the Cadillac level, and the Cadillac's like twice as much. So that is a possibility. So emergency plan. There are a couple of reasons why you should consider and be prepared for an emergency. One is dystocia, like Dr. James was talking about. Either you notice that there's an abnormal presentation when the foal is initially presented. If you palpate and there are 2 feet and a nose, then you're probably good. But if you feel 4 feet, or if you don't feel any head, any of those things obviously are indications that the presentation is abnormal. So that can be a situation where you're in a dystocia situation. And when the stages of labor, specifically stage 2, is prolonged. So stage 2 is defined by the period of time from when the mare breaks her water to when the foal is expelled. And so if that takes longer than 30 minutes, it's too late. So if you're in that situation and the mare is not progressing, I'm a bit of a wuss. I usually like 15 minutes. And if we're not seeing stuff, the mare needs to be up and walking, and I want the trailer ready to go. So have a plan for that. And that's where the stopwatch comes in handy. That's where taking notes on when the water is, when she breaks her water. And then if the mare has the foal and all of that goes well, then you start to think about your 1, 2, 3 post-foaling rules. And I don't know if everybody's familiar with this. It's pretty easy. Within the first hour, the foal should be standing. Within the second, it should absolutely have a suck reflex. And I would actually say like it should have a suck reflex within the first hour. Like I feel like most foals have a suck reflex before they're standing, but it's important that it's not as neat and it doesn't make their 1, 2, 3 work unless they like put suck reflex somewhere in the middle. And then within 3 hours, the placenta should be passed and the foal should be nursing colostrum. So if you have an emergency, you should know, who are you going to call? Does your veterinarian deal with dystocias? How far, like if you've been watching your mare and it's 20 minutes after she's broken her water, and your veterinarian is 45 minutes away, it now becomes a race against the clock, right? So you need to have a plan in mind so that you can maximize the chances of both the mare and the foal's survival. And that means if you're considering, if this mare and foal if you're considering referral as an option so that the mare can be dealt with at a referral hospital, you need to know, like, you need to load and you need to call your veterinarian and say, this is my game plan. And these conversations should be had before you're in the emergency. Like if you have a pregnant mare, talk to your veterinarian, say, this is what I'm planning on doing. I will call you. I will tell you I'm loading and going. I will tell you what the presentation is. Please call the referring hospital or the referral hospital. And that's a plan. So who are you going to call? Where are you going? Like clearly you should go someplace where they can deal with the situation, but you should have that in mind. Whoever's driving should know, oh, I'm going to Rhinebeck. They should be prepared that that's where they're going to go, and they should know how to get there. And then also, like, how are you going to get there is more about how the directions that you're going to take. It's more about, do you have a truck and trailer? Is it ready to go? And we've had places where, I mean, they want to do their very best by the mare and foal, but if you spend 40 minutes calling a van service, time is ticking. So be prepared for that. All right, going back to my colostrum soapbox. So everybody should have a refractometer. And the reason why I recommend it is twofold. One, you need to know if the foal that was just born if the colostrum that foal is going to get from the mare is good enough, or if you need to provide it with donor. And then the next question that I'm going to have you really focus on, because it's really important in my heart, is that I need you to think, can I collect and bank this mare's colostrum? So one farm that I know, they collect like 8 to 12 ounces of colostrum. They give the foal while it's down a bottle of the colostrum, and then they take the rest of it and they put it in the freezer. So it's a really easy process, and I highly recommend it, because then when you're in a situation where your next foal, the mare has like poor or fair colostrum, it's not going to get it done for that particular foal, and you can reach for your bank and you can provide it in a bottle at that time, or your veterinarian can tube the foal later on. There are different ways to collect the colostrum. You can either use an easy milker, where it's basically this gun system and it just puts it directly into your bottle. You can use an inverted syringe if you struggle with the easy milker, where you cut off the tip and you invert the syringe, use a 60 cc syringe and use that and just dump it into your bottle. And you can just use a measuring cup. If you're like gifted in the art of milking mares, a measuring cup will get it done. So I will say, like, I'm a fan of all of the Brix refractometers. Some of them, like this one that you can get from ARS, comes with gradations that shows it's very good, fair, and poor. I would actually say that I think I would say good is probably like closer to 25. I'm a little bit of a colostrum snob. So I just feel like you just have to put a lot more colostrum into the mare or into the foal in order to get the IgG to pass. So I usually say if you're like at 22 or above, you're probably going to be good, as long as that foal drank enough. Below that, if you have donor, I would consider it. So anyway, donate to our colostrum banks. Rhinebeck and Millbrook have a combined colostrum bank. And we are taking donations for colostrum that you gathered from the year before, or anything that you want to give us. It really helps. And then it's not something that we basically made a donation to the Foundation for the Horse for all of the colostrum that we sold to clients last year. So it's not something that we're trying to make money on. It's really something that we need for the benefit of the horse community. Okay. Yeah, Dr. Javsikas just said that Rhinebeck has bottles where if you need to go by and pick some up for this year. Also clean soda or water bottles will work in a pinch. And then we have gotten to a place also where we just buy those Easy Milker bottles. And so that way, if someone wants to use that and they give us a bottle full of colostrum, we're just going to, in that moment, give them a new bottle back. So the more that people the more participation that we have in actually collecting colostrum, the more this will succeed, because we don't have a lot of mares ourselves to make it work. So it really is community dependent. That's a really good question. The question that she asked is, how long does it stay good for in the freezer? And what I would say is my preference is for this season to use colostrum that we gathered last year at the early part of the season. Clearly, if you have colostrum that's like 2 and 3 years old, it's not as good. But people will, if you have a situation where a mare foals and then there's a dystocia and the mare doesn't make it, or there's any other post-foaling complications, we can still use that colostrum in place of milk sometimes. So I would say whatever you do, never throw it away. Like, bring it to either Rhinebeck or to Millbrook and say, hey, I've got this. Do with it what you will, because I think that sometimes we're in a situation where we don't have a lot of options, and we will use colostrum if we have it that's like 2 years old. Is it our preference? No, but we will. So I think if you have it, please don't throw it away. And then really quickly, I think everybody understands the value of a neonatal exam and IgG testing, but I want to point out, there are few exams on the horse where you get as many body systems evaluated as we do in a neonatal exam. We're looking, obviously, doing a TPR, listening for a murmur. We're looking at the eyes, doing an oral exam of the bite, palpating the thorax for fractured ribs, palpating the umbilicus, palpating for hernias. We're looking for angular limb deformities, and we're examining fetal membranes. And so I would say, you get a lot of bang for your buck when you let one of the veterinarians examine your foal. And for example, something like fractured ribs, it's really going to change how you manage that foal going forward. So if you don't know about it, and you turn that foal out, then potentially the fractured rib can do some damage. So we're always going to advocate for doing neonatal exams. And then there's variability between veterinarians in terms of what type of blood work they do in their standard blood work on neonates. But we're doing more and more CBC fibrinogens. Some practices do SAAs, and then obviously an IgG. And we have really moved away from qualitative IgGs where, you do the gamma check, or I would argue that the SNAP test is, in fact, it's a qualitative test. We're trying to focus more on getting an absolute number and doing a better job at identifying those foals that actually aren't passing. Because I have to say, I think for a long time, foals we think they've been passing and they haven't. And so when we think about what the ramifications of that can be, like joint ill and some of those things, it's really essential that these foals are starting off on the right foot. So, any questions? Yeah, no, I think I agree. So Annette wanted to add, we're going to make our rule 1, 2, 3, 4. And we're going to say like 4 hours should be passing the meconium. I totally agree with you, Annette. I think that that's a huge part of making sure that the foal's going to be comfortable, and having somebody looking out for passing the meconium is a big deal. What are my thoughts on adding oxytocin to your foaling kit? So I personally think that mares post-foaling are exceptionally sensitive to oxytocin. I think that if you're going to treat a mare with oxytocin, I think that she has to have retained her placenta for a good amount of time. I'm not an advocate for giving oxytocin to a mare that is on a normal schedule. She has plenty of endogenous oxytocin that I don't need to add it. In fact, I would be concerned about things like uterine prolapse. Sometimes mares can get exceptionally painful and crampy. And so I'm going to say no to that unless the veterinarian says, yes, the mare has retained for a period of time, go ahead and let's try this. But I would advocate, do not do any of those things without your veterinarian's advice.
Hi, everyone. Good morning. It's good to see you all here. My name, for those of you who don't know me, is I'm Dr. Atlanta King, and I am the specialist in reproduction with Millbrook Equine. And today we're going to be spending the next half hour or so talking about stallions and getting ready for the breeding season. So it's January now. It's cold out. Breeding season is at least 3 weeks away for some of you, and for some of you, it's probably even longer than that. But I think it's actually the perfect time to start thinking about getting your stallion ready for the breeding season, because it gives us time to address any potential problems so that we're not discovering these things when there's a shipment due out tomorrow. And it gives us also time to change our management plan if necessary. And also there's going to be some of the things that we're going to talk about, like vaccination and things like that, that require a bit of lead time. So most of the discussion today I'm going to spend on the breeding soundness evaluation. I think every breeding stallion should have an evaluation at the beginning of the season, so we know what we're working with going forward. And at the end, I'll talk a little bit about genetic testing that you may want to do, as well as the recommended vaccination schedule. So the breeding soundness evaluation is the examination that we do to make sure that your stallion is able to do his job. Okay, so we're looking at general health. We're looking at the health of the reproductive tract, both internally and externally. And of course, we're doing a semen evaluation. And so if everything goes well, then your stallion is ready to breed mares, but it also gives us a chance to identify problems. And as I mentioned before, we may need to change our breeding plan going forward. So general examination, of course, is important for every horse, and the stallion's no exception. Reproduction is sometimes thought of as a luxury item. So if there's limited resources available to the stallion, then they're going to preferentially put those resources into survival and not into reproduction. And also, general health, so debilitating conditions or poor health are associated with poor fertility and semen samples that are less than ideal. So we want to make sure that those stallions are healthy. I like for my stallions to be at a body condition score of about 5 or 6 at the beginning of the season, on the 9-point scale here. And remember that breeding mares is also very energy intensive. So stallions that are breeding every day or every other day tend to have a tendency to lose condition over the season. And so that's why we want to start at 5 or 6 and make sure that nutritional plane is maintained through the season. The hind limb soundness is also of particular importance in this exam. So getting up on a mount or on a mare's back is particularly straining on the hind end. So we want to make sure as much as possible that they have good health in their stifles and hocks and back. And then we're also looking for any hereditary conditions. Okay, so I think the most common ones that we look for in the general physical exam are malocclusions. So this would be a horse that would be excluded from a breeding program because of his severe parrot mouth. But there are also hereditary conditions that are coming to light now that we didn't used to know were hereditary. And I think, you know, they're worth thinking about in your breeding stallion, things like OCDs, kissing spine, things like that, degenerative suspensory ligament desmitis. Those are things that we're discovering now have a highly heritable component. And so we want to evaluate those things in the breeding soundness exam as well. So after we're finished with the general exam, we move on to looking at the reproductive tract. And we start by examining the penis and sheath. And we usually do that when the stallion's coming into the breeding shed and starts teasing the mare, drops his penis, and that gives us a good opportunity to take a look and look at the health of those structures. So this image here, sorry, I don't have a pointer, but the image at the top there is an example of squamous cell carcinoma, which is very common on stallion. It's common to find it on the non-pigmented skin. And also notable is that even solid colored horses can have pink spots on the penis. And so any horse that has them is very susceptible. This is a lesion that we probably would not be looking at in the breeding shed. Usually something this extensive would be found at home. The lesions that we tend to see, the lesions that we tend to see in the shed are more like this one here on the right. So it's very small and usually they're not even noticed by the owner. So that's an example of coital exanthema, also called equine herpes virus 3. And it causes blisters and erosions on the penis, which are quite painful for the stallion. And it can also be transmitted to the mare. So that's something that we're looking for. The bottom picture is demonstrating a case of habronomiasis. So those of you who spend time in the South might know it as summer sores. And they're worm larvae that's transmitted by flies. And since the flies like moist areas, they tend to happen on the penis more often. And actually this particular picture is showing, if you can appreciate, this is the urethral opening, and then this little red spot at the bottom is the summer sore. And I find those lesions in that particular location quite often, actually, probably because it's a mucocutaneous junction, it's moist, and flies like to go there. So all of these lesions can be really painful during breeding for the stallion, and they can also introduce blood into the semen, which is not ideal for fertility. So we're looking for all of those things. After we're done with the exam, the next thing we need to do is take cultures. Now, obviously, the penis is not a sterile environment, so we're expecting to find a healthy, robust population of bacteria here. But what we're looking for when we do the primary set of cultures is basically an overgrowth of a particular species of bacteria. So sometimes these stallions can get colonized with the wrong types of bacteria. Particularly what we're looking for is Klebsiella pneumonia and Pseudomonas aeruginosa. So those are two bacteria that are associated with uterine infections in mares. And so when they are overgrown on the stallion's reproductive tract, that can lead to transmission to the mares. I want to back up for a minute and just say that most uterine infections in mares are a mare problem and not caused by the stallion. So if you have a mare with a uterine infection, I wouldn't automatically jump to blaming the stallion, but certainly there can be transmission in some cases from the stallion. So that's one of the things that we're going to look for when we're taking our cultures. The other one is contagious equine metritis. So that is a true pathogen. It's not found in the environment. It's it's a venereal disease. So it's transmitted from mare to stallion, stallion to mare, and it causes severe uterine infections and abortion in mares. It's also a reportable disease. So it's fairly well controlled in this country. We don't see outbreaks very often, but in a full, complete breeding soundness evaluation, it'd be one of the things that we're looking for. And so these pictures are just showing you some of the sites that we culture. The urethral sinus, most of you probably know it as the spot where the bean grows, and it's a particularly bacteria-filled area. So that's one of the areas that we're looking at. The urethra, we look at the skin on the shaft of the penis and the sheath as well. And then so the next thing we would do is examine the testes or the scrotal contents. I've kind of put all of the external genitalia together here to talk about, but in reality, what we would do in the breeding soundness evaluation is usually a cursory evaluation of the scrotal contents before the stallion walks in the shed. So we would just look, make sure that there are 2 testes. So usually breeding cryptorchids or stallions with retained testes is frowned upon, making sure there's not a giant tumor or something that would probably end the breeding soundness evaluation at that point. And then we do the rest of the exam after collection. And that's because most stallions don't really appreciate having their scrotum handled. And so this way we can sedate them. That allows the testes to drop into the scrotum and we can get a really good exam. So the first thing that we do is palpation. This is a picture on the left here of a healthy, normal testis and epididymis. So that's what we're palpating inside of the scrotum. A normal testis should be about the size of a large egg, and it should have the consistency of a brand new tennis ball. So it's firm, but with a little bit of give. And then we're also palpating the epididymis here. This is the area where the semen is stored. It's not typically associated with major problems, but you want to make sure that it's oriented correctly. So it's towards the back of the scrotum. And occasionally we find things like calcified regions and things like that we could palpate. This image on the right is sort of one of the major things that I'm on the lookout for when I'm palpating the testes, testicular degeneration. So this can be caused by injury to the testis or can also be a normal age-related change. So eventually all stallions will experience testicular degeneration. The hope is that most of them won't have that problem until they reach their mid-20s, but we certainly see stallions that start to be affected in their teens and sometimes even earlier. So the picture on the left is these are a couple of castrations that Dr. Ferraro and I did. And the testis on the left is from a healthy 3-year-old. And the one on the right there is from a 16-year-old breeding stallion that I worked on for a number of years, who was experiencing testicular degeneration, and it eventually progressed to the point that he couldn't be bred anymore. He just didn't produce enough sperm. So you can see that the tissue of the testis has atrophied. The testicle is small, and when you palpate that, it's quite soft as well. So then we want to get some cold hard data. So we want objective measurements of the testicular tissue. So we're going to look at there's 2 ways that you can measure it. There's the total scrotal width, and we get that using these calipers. So you just place them on the widest point of the scrotum, and that gives you total scrotal width. And then we can also do it by using the ultrasound at different planes across the scrotum, and we can actually measure the testis. So we can measure height, width, and length. And since they're egg-shaped, they're an ellipsoid, we can plug those numbers into a calculation for the volume of the ellipsoid, and we can get the volume of the testis. And both of those measurements are associated with normals for each different breed. And so we certainly want to compare those results with average and make sure that they fit into the normal range. And we're also going to use those numbers to determine what the daily sperm output is. So just to back up for a minute and talk about physiology for 1 second, if you'll bear with me here. This is a section of testicular tissue under the microscope, and it's demonstrating what's called the seminiferous tubule. So that's where sperm is made. This is kind of the membrane of the tubule, and then it's filled with these progenitor cells at the bottom, whose job it is to divide and mature And as they move along the layers of this tubule, they become sperm. And I don't know if you can appreciate that, but these little structures here in the middle are sperm heads with their tail sticking out into the lumen of that tubule. And that is all there is in a testis. It's just packed with seminiferous tubules. So if you have a larger testis, you have more seminiferous tubules. And so you're making more sperm. You're just cranking out sperm all day. If you have a smaller testis, then you have less of the seminiferous tubules. And so we know that the weight of the testis is actually highly correlated with how much sperm that stallion is capable of producing. Larger testis, more sperm. And somebody's actually worked out that number. So each gram of testis will produce 18 to 20 million sperm per day. So we know that if we have measurements for the weight of a testicle on a stallion that we're evaluating, then we can determine what their total sperm would be for the day. It's kind of hard to weigh a testicle when it's attached to a stallion. So we use our measurements that we took for volume and we use those to approximate the weight. And then this formula down here is the formula that I use in order to estimate or to convert that number of what the volume translates to in terms of daily sperm output. So then again, we have normals established for each different breed. And we also use that number to compare to the actual number of sperm that we get when we do the collection. All right, so semen collection is the next part of the evaluation. And it's not just a means to get the semen. We're actually evaluating the stallion during this part of the BSE. We're looking at libido. Okay, sometimes they can have poor libido because of temperament or because they're novices. So they're like, they're not really sure what they're doing. But sometimes it can also be an indication of an endocrine problem, low testosterone, for example. The other thing that we're looking at is the ability to ejaculate. So this is Lee and I in the breeding shed with their cool little helmets on. And Lee's job is to tell me, because I'm usually under the stallion, her job is to tell me when the stallion is flagging. So she's looking at the tail, and when the stallion ejaculates, the tail pulses up and down, and that's related to the urethral pulses that occur during ejaculation. We do see a significant number of stallions that have trouble with this area. And, the most common reason that we see that they have difficulty ejaculating is pain. Okay, so a lot of times we'll see these stallions get on the phantom and they're interested and enthusiastic, and then right about the time when they need to start thrusting vigorously to achieve ejaculation, they'll kind of back right off. Some of those stallions are helped with Banamine or pain medication or attention to their back and hind end. And then in other cases, they actually have reproductive tract issues. So this is a cool case that I worked on in my residency. This was a stallion that had just a lot of difficulty ejaculating. He was a teaching stallion of ours. And sometimes we couldn't get him collected at all. And then he was later retired and euthanized for other reasons. And so we looked at his reproductive tract and we found that there was a very large cyst. So this arrow is pointing to the ejaculatory ducts. So that's the very tiny duct that the semen has to travel through in order to get to the urethra. Okay, the urethra is here. That's what we've opened here. So there's one, and there's the other duct. And you can see this white material in the middle is a very large cyst that's impinging on those ducts. And so he actually had mechanical trouble getting the semen to go through his reproductive tract. You can. It's very difficult to see because even though that cyst is comparatively large, when you compare it to the duct, it's quite small overall. So she had actually ultrasounded him. My mentor, Dr. Poser, had ultrasounded him and was suspicious that there was a cyst there. And that's why she was looking. And she has determined that that problem is actually more common than we used to think. All right. So after we've obtained the semen, the first thing that we do is look at the color grossly. It's a very good, the sperm cells are kind of the material in the semen that makes it white. And so if we have more sperm cells, we have a wider sample. So the first thing I do is kind of get a rough idea of what the concentration is by looking at it. The sample on the left is going to be a lot more dilute than the one on the right. We can also see funky colors. So pink means there's blood in the semen. Red means there's a lot of blood in the semen. And we don't usually see this degree of blood in the semen except when there's a tear in the urethra, which is also a common affliction of stallions, because the pressure in the urethra is so high during ejaculation, it can actually cause tears there. And then smaller amounts of blood we see with tears. We also see them with infections and some of those penile lesions that we were looking at before. Then again, we want data. So we're looking at volume. We're going to measure the volume, and then we have a machine that is going to actually give us a number for concentration. So how many sperm per milliliter are in that sample? I have a lot of clients who worry about concentration a lot, especially if it gets, too dilute. The volume and concentration are sort of inversely related. So when you have a higher volume, you'll usually have a lower concentration. And that's just because the volume is determined by the amount of fluids that are added to the sperm during ejaculation. Okay, so more fluids means more volume. It also means less concentration. And this is usually a product of how much the stallion has teased that day. So if he's been housed across the barn aisle from a bunch of mares that are in heat, you're going to get a high volume and a low concentration. Whereas if he just walks off the trailer into the shed and you get him collected on one mount, then you're usually going to see a much more concentrated sample with less volume. So, I forgot to show you that one as well. That's a yellow sample, which is a stallion that had urine contamination of his semen. All right, so back to concentration and volume. So the number that's a lot more important than either of those two numbers is going to be the total amount of sperm in the ejaculate, and we can easily calculate that by multiplying concentration and volume together. All right. Then we're going to, usually in a breeding soundness evaluation, we're going to do 2 collections that are an hour apart, and that's because that epididymis that I was showing you earlier does store quite a lot of semen. And so the first ejaculate will usually have a much higher amount. And then we expect the second collection to have about half as much sperm in it as the first one. And the idea of that second collection is 2 things. One is that we're getting a little bit closer to the daily sperm output because we've gotten rid of what's stored. So that should be a more closer approximation of how much sperm that stallion is making in a day. And the other reason is that when we go to evaluate that sperm, we want to get rid of the stuff that's older and maybe not as viable as the fresher stuff. So we want a nice fresh sample to evaluate. And then once we've calculated what the second ejaculate total sperm number is, we can then compare that number to the number that we calculated earlier when we were taking measurements of the testes. And if we have major deviations from that, then we know that there's a problem. So if we calculated much higher number and then we actually get a lower number, then maybe we have a tumor or maybe we have testicular degeneration happening. But more commonly, what we see is a much higher number. And that's a problem that a lot of stallions have called accumulation. All right, so in the normal stallion, the epididymis stores semen for about 5 to 7 days, and then it has kind of a self-cleaning mechanism where it will get rid of all of those old semen and void them in the urine. But some stallions don't have a very functioning system that way, and they just keep storing and storing and storing, and that semen gets too old, it starts to die and degenerate. And so when we go to collect them, we get a huge number of sperm cells, and they're very degenerated. So in this sample, you can see most of the sperm in the sample are just heads with no tails because they're degenerating and dead sperm. And then this picture here, so sometimes they can accumulate so much that the sperm actually starts to form a concretion, like a plug, and it actually forms a physical blockage. So in those stallions, we'll collect them and we'll get no sperm at all, even though it's clear that they ejaculated, and that's because the sperm is just blocked from coming out. So this is a plug that we were treating a stallion who was plugged and did succeed in removing that plug. And then they usually require a whole bunch of collections to get rid of all that old stuff after that. So after we do that, we do the semen evaluation. Morphology, which is examining the structure of each individual sperm. We usually count about 100 of them and evaluate them to see if they're normal or if they have structural problems. That's probably the test that we do that's most closely related to fertility. And we like to see at least 60% normal cells. Round cells, I should have put a picture of a round cell, but basically it just looks like not a sperm, just a big round cell. Those can be immature cells, or they can also be white blood cells. And neither of those things are things that we would want to find in our sample. Motility, of course, is also important. So we want to make sure the sperm is moving and it's moving progressively forward. And for stallions to pass their breeding soundness evaluation, we like for the progressive motility. So the sperm cells that are moving progressively forward, they're actually going somewhere and not in a circle. We like them to be at least 50%. And then in our lab now, we have the capability of using some special stains with a machine to count. So we have this stain that can only penetrate a damaged plasma membrane in the sperm cell. And so we can actually count up in the sample what percentage are viable and which ones are not viable based on the way that they stain. Those are just some of the tests that we do in the lab routinely on a BSE. There are dozens of other tests that they can do that we can ship the semen out and do special tests, but those are usually reserved for stallions who are having specific problems. So we wouldn't do them in an ordinary BSE. And then we can look at the internal reproductive tract. We can do that by both ultrasonography. So looking for things like those cysts that I was showing you, looking at the accessory sex glands, make sure that they look healthy. And then we can also do urethroscopy, where we put an endoscope into the urethra. That would be looking for things like those urethral rents. This is an image of the ejaculatory ducts. So we're looking here to make sure that there's no signs of infection. This isn't something that we would do routinely again, but if we have a stallion with a history of problems, or we've identified something on the breeding soundness evaluation that wasn't quite right, then we could do that as well. So hopefully we can use that information to maximize fertility of those stallions. Here are some changes, depending on what we found on the breeding soundness evaluation, some changes that we can make to improve fertility. Stallion housing is a big one. So stallions that are housed together, it's been shown that usually there's one dominant stallion, and the other stallions will often, who are kind of the submissive ones, will have lower levels of testosterone and changes into their endocrine profiles. So if we've identified stallions that maybe don't have good sperm output or have low libido in the shed, moving them away from other stallions can be very helpful. Supplements, there are some great supplements out there. Antioxidants, especially ones containing alpha lipoic acid. There's been a lot of studies coming out on that in recent years. It really helps to, so the sperm is basically just a packet of DNA, and it has a bunch of mitochondria at the back to power the tail. And the mitochondria are what produce a lot of free radicals. So sperm cells are very susceptible to damage by free radicals. And so anything that we can do to help minimize the free radical damage in those stallions is helpful. All right. And so alpha lipoic acid, vitamin E and C have been shown to be extremely beneficial. Omega-3 fatty acids, in my experience, they've been helpful with stallions that don't cool very well, but generally they don't help fertility for stallions that are doing live cover. And then L-carnitine is another one that you'll find in a lot of stallion supplements. Lighting programs. So we talked a little bit this morning about Equilume and lighting programs for mares. stallions are also long day breeders, just like mares are. And so we find that in the winter months, their sperm output is much lower than in the summer months. And so that's what this graph is showing you. So the summer is here in the lighter blue, and then the winter in the darker blue. And then at the bottom, you have age. Okay, so not surprisingly, as the stallion's testicle gets bigger and bigger as they get older, they start to put out more sperm. But you'll see that they are producing significantly more sperm in the summer than they are in the winter. So if you have a stallion that's breeding in February or March, it might be beneficial for that stallion to be under lights, just like your mare would, starting in December 1st or so. And then extender trials. So sometimes we can pick up the quality of semen, of sperm cells with certain additives in the extender. Pentoxyphylline is one that tends to give sperm a big boost. So when we see stallions that have motile semen, but maybe not as good as it could be, so the velocity of that semen is kind of sluggish, we can often improve that with additives like pentoxyphylline. And then and cholesterol also can help with stabilizing sperm membranes and helping with viability of that sperm. All right, so that's the bulk of things. How much time do I have left? Should I wrap things up here soon? All right, I'll just briefly go over genetic testing here. So each breed kind of has their genetic problems that are kind of controlled by a single gene, usually transmitted through dominant or recessive pathways. And we have a lot of tests available to us now to sort of screen those stallions and make sure that the genetics that they're passing on are healthy. Okay, UC Davis has over 60 tests available. I think the Animal Genetics Lab also has a bunch of them. They're usually pretty inexpensive, $40, I think, for a basic one. And that can tell you if your stallion is a carrier for a number of the diseases that you might see in your breed. They also have color coat panels. So if you're interested, you know, I have some dressage clients who only want black foals, for example. So they want to know if their stallions carry double black genes so that they can make sure that all the foals turn out black. And they use that to kind of as a bonus for advertising their stallion. To take a genetic sample, it usually requires the roots of the hair. So you can see in this picture, right? You can't just cut the hair. You have to actually pull it out so that you have these little root balls, because those balls have the cells attached to them, and that's where the DNA is going to be extracted from. And that's probably all I'll say about genetic testing. Vaccination. So core vaccines are something that we recommend for every horse. So tetanus, Eastern Western encephalitis, West Nile, and rabies. Every stallion, every horse on your property should probably be getting those. And then for the stallion, we look at some of the other things that are of particular importance. So contagious diseases, these stallions are usually coming, if you're doing live cover or pasture breeding, they're coming in contact with a lot of other outside mares. So equine herpes virus 1 and 4, particularly important when stallions are coming in contact with mares because it can cause abortion. Flu, strangles, and then also diseases that cause high fevers, which include all of the diseases that I just mentioned, as well as Potomac. So fevers are very bad for stallions. There's a reason that the testicles sit very low in the scrotum. It's because they like to be cooler than body temperature. And so when stallions get fevers, it can interfere with the processes in the testes that produce sperm. And so, and these changes can be evident for up to 70 days after a stallion has had a bad fever. So we definitely want to avoid during the breeding season their possibility of getting any prolonged or highly elevated fevers. So these are all things that you're going to want to do. I also particularly recommend strangles if you're doing a live cover situation, because strangles running through a breeding farm is not fun. And then for the stallion, particularly, we worry about EVA, equine viral arteritis. If you were here at my talk last year, we talked extensively about EVA. I'll just kind of brush on it quickly. So it causes a lot of non-specific signs, and they're usually quite mild. Depression, hind limb edema, cough, nasal discharge. In the stallion, it can also cause scrotal edema, which also, insulates this. It insulates the testes, so it's not good for sperm production. But the bigger problem when it comes to stallions that we're concerned about is that they have the potential to become long-term or even permanent carriers of this virus, and they shed it in the semen. So it can be shed via the respiratory route, but also in stallions through this venereal transmission. And so they can breed mares. It survives shipment, it survives freezing, so it doesn't even matter if it was live cover or not. They can breed those mares who usually live on a breeding farm, and then those mares will then shed through the respiratory route and spread it to the other horses and cause abortion. So we want to, of course, avoid that situation. And there's two different ways that I recommend for controlling and preventing this. One is to test, at the bare minimum, test your stallion every year for EVA to make sure that they haven't picked it up by the respiratory route somewhere at a show or anywhere else they came in contact with other horses. And then I strongly recommend vaccination. It's a very safe and effective vaccine. Some breed registries require it, but not all. But there's a few considerations that you have to take before you vaccinate. So the biggest thing is that movement of horses, this is a disease that's controlled for in imported and exported horses. And most countries control for it by doing a blood sample test of the horse. So if your horse is positive, they may be denied entry. After you vaccinate your horse for EVA, they'll always be positive. They'll always have antibodies and test positive on that blood test. And it's not able to differentiate if they became positive through vaccination or natural infection. And so the most important thing to do before you vaccinate your stallion is to draw the serum, take a blood test, prove that it was negative, and then immediately vaccinate that stallion. Okay. And then you keep that negative result forever. And you also keep records that you have kept up with the vaccine on a yearly basis forever, because otherwise somebody might say, well, that could be a natural infection and we're not letting that stallion come here. After vaccination, the first time, it's a single injection. Even the first time, it's not required to be boosted, 3 weeks later, like most vaccines are. But what is required is a quarantine period after the first time that the stallion's been vaccinated, which is kind of a pain. But the concern is that it's a modified live vaccine. And so those stallions may shed the vaccine variant of the virus and cause another horse on the property to test positive. It's not medically a problem, but it's from a testing standpoint, it can be a problem. And so that's why we vaccinate, or why we quarantine for 3 weeks. All right, that's it. Does anyone have any questions? Oh, so the pentoxifylline was actually, it's an additive and an extender. In the extender, yeah. So there's Botu Semen Turbo. What's that? That's a good question. Someone should do a study on that. Yeah. Oh, I'm sorry. The question was, if we put the stallion on pentoxifylline systemically, will that improve our semen parameters? And the answer is, I don't think anyone knows for sure. But it would be an interesting thing to check out. But certainly if you're doing, reinforcement breeding or anything like that, it would be a good one to use. Yeah. Urine in the semen. It's sometimes caused by neurologic problems. So the kind of switch over. So in order to have the ejaculate come through without urine, the sphincter to the bladder needs to be tightly closed, or else it gets urine contaminated. And so sometimes we see that in debilitated horses, neurologic horses. And sometimes it just happens for no apparent reason. And in some cases, like the case that I put up there on the slide, that stallion had never had a problem before, and he never had a problem since. For whatever reason, he just did at that time.
All right, I'm gonna get started with our last talk before lunch. I am Dr. Lauren Pash. I'm a therogenologist at Rhinebeck Equine. And my talk is going to be on periparturient complications in the mare. Mainly postpartum, I just like the word periparturient. So this is really just looking at this kind of a laundry list of all the things that can go wrong when your mare foals. There's some more shocking pictures, I guess, and some of the conditions we'll talk about are more urgent or emergencies. And I'll try to touch on what is truly an emergency, what is life-threatening, how common are these things. So this isn't a freak out, all these horrible things are going to happen when my mare foals, but like we talked about a little bit this morning, it's not a benign process. And so I think the more you know about what could happen, the better equipped you are to deal with things. So every mare should have a complete physical exam, usually within 24 hours of foaling. And in addition to doing a thorough systemic exam, we want to make sure that we're looking at the organs that are most immediately involved in foaling. So we're going to be looking for vulvar trauma, and also looking at the udder in particular, making sure that it's soft and well nursed. And then we also need to make sure that the fetal membranes are examined for completeness and any abnormalities. This image here is just an example of a pretty thorough postpartum mare exam sheet that can help you just make sure you're checking everything you need to. So it's well beyond the scope of this talk to go through what normal and complete fetal membranes look like, but just so everybody sort of has an idea. We have a picture here on the far side from me. That's the allantoic surface. So that's that silvery side. And then the red velvety side is going to be the opposite. So that's the chorion. This is in a nutshell how it should look. And the main thing you want to pay attention to with this part of the placenta is going to be those two horn tips and making sure that they're complete. And then this is what amnion should look like as well. Thin, translucent, and we don't worry about completeness as much with the amnion in the same way we do with the chorioallantois. And then again, just real quick, this was already touched on this morning earlier, but what's normal? The 1, 2, 3 rule. And beyond that, sort of looking at the mare in particular here, as opposed to the foal, it's not abnormal to have a mildly elevated heart rate. Post-foaling, it's a traumatic event. Similarly, there is going to be some expected amount of local vulvar trauma. I'll show you some examples of more extreme trauma a little bit later on, but just sort of keeping in mind that this mare did just produce a foal, and there's going to be some lingering effects from that, which hopefully will normalize as time goes on. So the first complication I want to talk about is retained fetal membranes, or retained placenta. So it's not common. You can see here 2 to 10% of foalings with certain breed predispositions, but of all the complications I'm going to talk about today, this is probably something that everybody is going to see at some point. So there are a portion of mares who don't follow the 1, 2, 3 rule and will fail to pass their fetal membranes within that expected timeline of 3 hours post-foaling. So normal expulsion, the process that lets that happen, starts immediately after the umbilical cord ruptures. So this is why anything that is going to cause an abnormal foaling, so dystocia, C-section, high drops, abortion, anything that interferes with that normal process can predispose a mare to a retained placenta. So the most commonly retained portion is going to be the non-pregnant horn tip. That's the horn tip that tends to be thinner. It's more intricately interdigitated with the endometrium in that horn, versus the pregnant horn tip, which is usually pretty edematous. There's a lot of local trauma there from the fetal feet. But although that's the most common thing to be retained, or the most common portion to be retained, any little bit of placenta can cause metritis and all of the unwanted complications. So identification of the problem is the first and most important step. So that's why it's always important to save your placenta. Have your veterinarian perform a pretty thorough exam, make sure that it is normal and complete. If the placenta is shredded or not recovered, the mare should ideally be examined. For me, I like to do a transrectal or transabdominal ultrasound, usually a manual vaginal exam. If you can't find any retained placenta, but you haven't seen it on the ground, the safest way to approach that would be to just monitor that mare very closely for signs of metritis, and then follow up as the uterus involutes and gets smaller. Your vet will be able to examine the entire uterus and either confirm the absence or presence of retained fetal membranes. If we do decide there are retained fetal membranes, there are a handful of methods that your veterinarian can use to try to remove them. Regardless of that method, we're going to follow it up with copious uterine lavage, and in most cases, systemic antimicrobials. So if we can recognize, diagnose, and treat a retained placenta early, we can usually avoid some of the life-threatening complications, which would be metritis. So metritis is not the same as endometritis. Endometritis is an infection of the endometrium, so just that very inner layer of the uterus. So when we talk about like a post-breeding endometritis or a bacterial endometritis, something that we're treating with local antibiotics, you know, to help your mare get pregnant. This is a different situation. So metritis refers to that inflammation going through the entire uterus. It's a systemic illness. So these mares are usually going to show the classic signs of endotoxemia, tachycardia, fever, toxic mucous membranes. There will often be, but not always, a pretty smelly uterine effluent. Often these mares who have metritis, it's secondary to either retained fetal membranes that haven't been addressed adequately or quickly, or dystocia, events that are sort of setting up an environment for exponential bacterial growth. If this sort of systemic disease isn't treated and resolved quickly, the big thing we worry about with horses is laminitis. So if we get systemic inflammation, that's probably the most common life-threatening sequelae. So treatment involves addressing the inciting cause, whether that is a retained placenta. Uterine lavage is always going to be helpful in these cases. And then the remainder of the treatment plan is really going to be looking at systemic support. Broad spectrum antibiotics, NSAIDs, laminitic support for the mare, whether that's soft rides, deep bedding, ice boots, and just really monitoring the systemic situation beyond just the uterus. So periparturient hemorrhage is another possible complication after foaling. This usually occurs during foaling, and then we see problems in the immediate post-foaling period. Less common, but still possible. Mares can have some uterine artery hemorrhage or bleeding during pregnancy or up to a couple days post-foaling. So it's typically going to refer to a rupture or tearing of, I just put uterine artery to give myself some wiggle room there. It's typically the middle uterine artery, can also be the uterovarian arteries, external iliacs. There are a number of vessels that can be affected. And when that vessel either tears or ruptures, the hemorrhage can go into either the broad ligament, which in this picture here is this sort of sling-like support that really the whole uterus is hanging from that. Has a finite space within the broad ligament. So when mares bleed into the broad ligament, it typically becomes more painful as opposed to shocky, because there's a limit typically to how much blood can go into that confined space. Similarly, mares can bleed into the uterine wall or the uterine lumen. And then the most fatal option is bleeding into the abdomen. So this is a pretty well recognized but poorly understood problem. This is a little bit older, but a 2012 paper from the University of Kentucky, and they're looking at necropsy records from a 15-year period. So these are all horses, keep in mind, that are in central Kentucky. So there's a lot of brood mares, and these are horses that are dead. But within that 15-year period, 1.5% of the total equine necropsy cases were uterine artery rupture. So It's not a very common cause of fatality in horses, but it certainly can be. It is more common in older mares than younger mares. And in my experience, once a mare has bled, she is at greater risk for repeat bleeding in future pregnancies. And this is something that a lot of these problems we associate with dystocias or traumatic foalings, but this is something that can happen just as easily with an uneventful normal foaling. So the clinical signs are not terribly specific. Restlessness, a lot of colic-like behavior. These mares are going to usually be quite tachycardic and have pale mucous membranes. And the treatment principles, I don't want to go into this in too much depth because there's a lot of different opinions within the details of how to treat, but the biggest thing is to avoid stress and maintain a quiet environment for that mare. So for me, that typically involves avoiding trailering. We want to keep the mare calm. We want to avoid doing something that's going to cause changes in blood pressure, because if we have a clot that's formed, that's going to affect how stable that clot is. Again, depending on where the mare is bleeding and what her systemic situation is, fluid replacement, it's the type of fluid and the amount that might change. I think pretty universally, veterinarians will use Amicar to help stabilize that clot. I found acupuncture for mares who are amenable to acupuncture already to be quite helpful. And then different types of sedation. So, when this happens, if a mare bleeds into the abdomen, the reality is it's probably going to be fatal, but there are a lot of bleeds that are not hemorrhage into the abdomen. And if you recognize them and treat them appropriately, those mares can go on and do fine. So I'm just going to mention a little bit, because I brought up that one of the clinical signs of hemorrhage could be colic-like behavior. So normally we see colic-like behavior, we think GI tract. Postpartum mares can have all of those same signs, and it could just as well be the reproductive tract as the gastrointestinal tract. So when you see a postpartum mare with colic signs, it's important to sort of tease out, is it her GI tract or is it her reproductive tract that is causing her pain? I'm not going to go into a lot of detail here, but I just want to establish that mares are at an increased risk for some GI issues in the immediate postpartum period. As we've mentioned, this is a traumatic event, so you can have damage to portions of the gastrointestinal tract, either the small intestine, colon itself, or the mesentery, which can lead to ischemia and potentially peritonitis. Large colon volvulus is another GI thing that I think is pretty high on everybody's list post-foaling. There's a lot of extra space within the mare after she has foaled. And so there's going to be a lot of changes in how the GI viscera sit, but that's sort of a trademark post-foaling type of colic would be a large colon volvulus. So these are some pretty gnarly pictures of vulvar trauma, which is very common, not always in this severe, not usually in this severe of a fashion. So rarely, if ever, is vulvar trauma going to be life-threatening, but I find that it is often an indication of deeper trauma. And that may require some further investigation. So the mare on the right here with the hole right here, I included this. So she had some moderate vulvar tearing, which we repaired, but because of the degree of trauma she had, we did do a more extensive vaginal exam, found there was vaginal trauma as well, laceration, which abscessed, and ultimately the abscess drained out cutaneously rather than into the reproductive tract. So that's something that can happen. These are extreme cases of vulvar trauma after dystocias. If a mare has this much trauma going on, chances are there are other problems as well. There's a reason it got to that. Usually a prolonged dystocia. So again, it's not that this isn't a problem, but this in and of itself is not going to be the life-threatening issue. but it can be a good indicator that there are problems further into the reproductive tract. And again, depending on how extensive and how deep the trauma is, sometimes we may do a staged repair. This tissue is going to be really inflamed and not want to hold sutures or heal well at this point. So sometimes we might do a temporary closure just to prevent the mare from aspirating air while things quiet down. But the vulva here heals remarkably quickly. So on the topic of lacerations and trauma, perineal lacerations and RV fistulas or rectovaginal fistulas. So perineal lacerations, a first-degree perineal laceration, it's not something we usually even discuss, but technically that's just tearing of the vulvar lips, and that's a pretty common finding after foaling. We can have a second-degree laceration, and those are mares that are going to have more involvement of the perineal body. And then I'm going to just flip forward and I'll go back to that other slide, but this is a third-degree perineal laceration. So we have complete tearing of the perineal body so that there's now a cloaca. There's a common opening that you can see here. And then once we look a little closer into the reproductive tract and the rectum. And so this happens occasionally during foaling because, as you can see here, the rectum is going to be situated right above the vagina and the pelvic canal here. And so if a fetal extremity goes up the wrong way, that can either, so the foot goes up into the rectum, it can either tear all the way out, giving you that cloaca, that third-degree perineal laceration, or sometimes the foot can come back through and then everything comes out the right hole. In that case, you have a rectovaginal fistula, so you still have that communication, but it's a finite hole that's a little bit deeper into the reproductive tract. Although it can be quite alarming when it happens, this is not typically an emergency. This is something that we usually will wait until the mare has been weaned, things have quieted down, timing is a little bit less particular, and we can do a standing repair several months later. If there is very minimal trauma and tissue necrosis, some of these can be repaired immediately post-foaling. These mares do have a very good prognosis for future fertility. It's really just a matter of recognizing the condition. And obviously, if we have a third-degree laceration such as this, we're going to worry about fecal contamination in the uterus. So these mares need to be cultured and worked up appropriately for that reason. Vestibular bulb prolapse is not something that is always discussed in these kinds of lists, but it's something that I personally see often enough and get asked about often enough that I just wanted to mention it. So the vestibule refers to that area just inside the vulva. So it's technically the area that is both the reproductive tract and the urinary tract. It's the vestibule, it's like the foyer, it's the little entry area. The vestibular bulb is on either side of that vestibule in the wall. It's this flattened sort of oval of erectile tissue. And so erectile tissue just means that it is highly, highly vascular. And it helps to sort of hold the penis in place during natural cover. So that's what it's designed to do. Because it is so vascular and given its location, it's not uncommon that this gets traumatized during foaling. So the picture on the far left is sort of an in situ look at what that vestibular bulb looks like before it is prolapsed. As it gets more inflamed and bigger, it can prolapse. So that's the second picture here. I've gotten a lot of calls from people that think it's just a sack of blood and they want to lance it. It's not. So what I like to do is basically replace it. So you can use a lot of SSD, sedation. Typically, you can sort of slide this back into the mare, and then I'll put a caslix in. Sometimes it's a pretty deep caslix. This might be the same mare a little bit later, but you can see here sort of in the shadow, if this structure is not replaced, it's going to become necrotic, and you're going to get a lot of just local tissue necrosis on the outside, and that's where this sort of starts to turn black. So bottom line, when you see it, it's something that should be not cut out, not lanced, but replaced. And once that's taken care of, they usually heal quite quickly. There may be a little bit of a delay in breeding the mare. Maybe this is a mare that doesn't get bred on full heat, but they do heal and rarely interfere with the rebreeding timeline in my experience. Uterine prolapse. These are not common, but when it happens, it's as much of an emergency as there ever is. So this is something that happens in the immediate post-foaling period. Sometimes it's associated with retained fetal membranes, sometimes not. Sometimes it happens in maidens, sometimes it's in multiparous mares. In my mind, it's something I've always associated with dystocias, but it happens with normal foalings as well. There's a recent retrospective that showed that Arabian mares may be overrepresented, but when this occurs, it's truly an emergency and requires immediate veterinary attention. So if you're on the farm and this happens, what do you do in the meantime? If you have sedation on hand and that's something you're comfortable using, keeping the mare calm is going to be of the utmost importance here. The mare who's not calm, who's worried about her foal, you have this very heavy, very vascular structure hanging out, and you can have, so the life-threatening complications that can happen because of that would be uterine tears, and I think most importantly and immediately, the uterine artery rupture or periparturient hemorrhage. And, you know, that happens as we have this excessive amount of weight that is pulling backwards. And then you can get a lot of blood on the floor, and then the mare slips, and then their uterus hits the ground and it's dirty. So calm is the way to go with this. I don't say this as something that you should like write down, do this when this happens, but something that can be done in certain situations. You're comfortable with it. The mare is sedate. You make sure your foal is safe, assuming the foal is alive. And then something you can do before a veterinarian arrives is take a clean, heavy duty trash bag. And you can take two people and kind of sling the uterus up behind the mare and keep it at the level where we have it in this picture. And that's going to be key in helping to reduce all of the weight on the uterine arteries, helping to protect it from trauma, keeping everything just a little bit tidier and safer. So when your veterinarian is addressing this, we will examine the uterus the best we can while it's still prolapsed for any sort of tears, endometrial vessels that are bleeding. We can address that before replacing it. We want to clean the uterus and then carefully replace it. So this is something where you want to make sure you're using fists and not fingers. This is a friable tissue, and you start replacement closest to the mare, so closest to the vulva, and you just sort of fist in a little bit at a time. Once it's replaced, as long as the uterine horns are not intussuscepted, so that's something you have to make sure, the vet has to make sure happens after replacing a prolapse, is that both of those uterine horns have to be completely extended. And usually that's farther than our arm can reach in the immediate postpartum period. So my preference is large volume lavage following replacement, but in theory, a healthy, normal mare, if everything has been replaced and is in its correct anatomical position, shouldn't continue to prolapse. The mares I've seen with repeat prolapses have had significant systemic issues. And this is something that, not that you shouldn't do a Caslix, but a Caslix isn't going to hold a uterus in if it wants to prolapse. This is a really big, heavy structure. And so in my experience, the best way to address it is to get it in the mare replaced in its normal anatomical place, rather than trying to hold it in with extensive Caslix and sutures through the vulva. Uterine tears are also uncommon. Can happen due to, so they're more common after a dystocia because we're gonna have more manipulations, more straining, but can happen because of persistent straining against an obstruction. That could be the foal in a malposition or presentation, fetal extremity that either, you know, applies blunt trauma to the uterine wall or directly perforates. And then also this can happen iatrogenically due to overaggressive manipulation. So they can be full thickness or partial thickness. And the size really varies and is going to, in most cases, dictate how you treat this. every once in a while you will find, so this is sort of, in my experience, the more typical size of a uterine tear, and this was sort of mid-horn, but the location and the size are going to determine how easy it is to really diagnose that tear, whether you can reach it manually, whether it's something you go to do a vaginal exam and, an entire foot came through the uterus and there is GI contents within the uterus. Those are really obvious cases that need surgery. Partial thickness, tiny holes, we want to work on often treating medically and reducing that abdominal contamination. Sometimes these are really, really obvious, and sometimes they can be a little bit trickier. So I think it's something to just sort of keep in the back of your mind. The appearance of the placenta when we're examining it, if we see focal bruising, can certainly give us, an idea that there might be trauma on the next layer, that being the uterus. All right, and then real quick, I just want to touch on two potential issues with the mammary gland. So the first would be hypogalactia or agalactia. So mares that have poor milk production, basically. And the causes are numerous. Fescue toxicity is sort of one of the more obvious ones. And usually we can find out if a mare has been grazing on fescue infected pasture by asking some questions about her history. Skinny mares will often fail to produce an adequate udder. And sometimes maiden mares just don't produce milk the way that we want them to. So treatment, pretty straightforward. If we can identify an underlying cause, we should try to treat that. Whether it's removing the mare from the fescue pasture, feeding more, trying to increase our plane of nutrition. Domperidone, brand name Equidone, is going to be our friend with these mares. But I just wanted to note that sometimes there's nothing you can do to provide enough milk for that foal. And that's when we need to think about supplementing the foal or getting a nurse mare. And know going into the next year that this may be a repeat problem for this mare and try to head it off before we get to late gestation. And then mastitis is the last thing I want to mention. So it's not common in mares, and it's even less common at foaling, but we're talking about the udder. So we're going to talk about mastitis, but most common after weaning, if we're going to see it in mares. Clinical signs are what you'd expect: local heat and pain. If your veterinarian is able to express milk and look at that on a slide, you'll see an increased white blood cell count. So my preference for treatment is appropriate systemic antibiotics based on a culture. So ideally you would culture some of that milk. In the meantime, while you're waiting for results, you can keep the mare comfortable. NSAIDs are usually helpful: hot packing, stripping out the udder if she'll let you, and then treating systemically as opposed to locally is more effective in my experience with appropriate antibiotics. So again, not super common in the immediate postpartum period, but certainly it's a time that the udder is being asked to work hard, and something to be aware of. So in conclusion, hopefully this wasn't just a scary list of all the bad things that can happen, but complications do happen. And I think knowing what's normal versus abnormal and knowing what is truly an emergency, what do I need to act on right now versus tomorrow? Annette.
I've got a question for Kate.
Yeah.
So this person says, first two foals were out of maiden mares. Each time it took both foals 3 hours to stand, then 3 hours to feed, mostly because of the first time mothers moving away from the foal. How common is that?
I think it's fairly common. Maidens can have quite a hard time with the emotional aspect, I think, of foaling. Sedation is your friend. And yeah, I think, and that's sort of what I was maybe getting at with, the what's normal, that there is going to be some expected nervousness, tachycardia, pain, all of that. So I think the maiden mare that doesn't want to be with the foal, doesn't want to let the foal nurse, sedation and making sure that that mare isn't painful. I'm looking at you like you asked me the question, but
My first 2 things.
I think ruling out ruling out the source of pain as that mare's behavior, Banamine post-foaling is always a good idea. But is she nervous or is she painful? Like, why is she not letting that foal nurse and addressing that either with NSAIDs for their workup or sedation? And typically it's a process that they can grow together with. Yes.
I had a maiden mare who clearly was bonding with her foal and was very excited about it. But I think she had so much milk ready, she was painful.
Yep.
So I was able, with someone holding the mare, to take a little colostrum out and, feed the baby with that. And then
Yep.
she felt better. And this about the time I was starting to really worry if they were ever going to, get it together. As my vet was walking into the barn to do the IgG, we could hear sucking noises.
Yeah, well, so when the mare has a really full udder, the foal has a nurse, that mare is painful, it's a great time to milk her out and get some colostrum for the colostrum bank. And alleviate some of that pressure as well. Yeah, and
I had a question about prolapsing.
Yeah.
Is how important is time? So like say the mare is starting to prolapse, you have like maybe this much showing and your vet is an hour away. Doesn't it make sense to push it back in because that's better than it coming all the way out?
In theory, yes, but it's my experience that you will not be able to push it back in.
Because the mare's still straining?
Oh, yeah. Yeah, sorry. The question was, if you have a mare that is starting to prolapse and you can see the uterus starting to prolapse, but it's not completely out, is it better to push it back in before complete prolapse if your vet is a long ways away? And I've seen, there's a Hackney mare. This little Hackney pony had a completely normal foaling, started to prolapse her uterus as soon as the foal was out, and multiple people were like, well, hold it in. And I mean, the mare is this big and she's still, so that force of the uterine straining that is causing the prolapse, I worry that pushing against that is more likely to lead to tears. The fingers, not fists. There's just a shocking amount of force that it is coming out with. So in theory, yes, if that could be done safely and effectively, that would be a good way to go. But I think in reality, usually by the time you notice this is happening, it's out. And then it's sort of a matter of, can we keep it clean, elevated, safe until we can get somebody here? Yes.
You want to briefly mention full reduction hormone protocol?
Yeah. So on the topic of maiden mares not letting their foals nurse, there's pain, there's nervousness and anxiety, and then there's like full-on foal rejection. And those are typically mares that aren't just like sort of lukewarm but towards their foal, but more like I might kill you, full-on aggression. So there is a pretty effective protocol, and it's the same protocol that we'll use for nurse mares to get them to adopt the foal, which is high doses of prostaglandin. So if you're using Estermate, we'll usually do, I want to say 3 to 5 mils, and it's usually 2 to 4 mils of luteolase. Enough prostaglandin that the mare is going to be crampy and sweaty and thinking about her sweaty, crampy self and not her baby. And in that time, there are other little sort of tweaks to this protocol. But typically, if you reintroduce the foal, you put the mare's sweat on the foal, you could rub placenta on the foal, but that mare in her super crampy, painful state will often re-accept the foal. But that is, thank you for mentioning that, a very different condition than just the painful mare that's sort of walking away from the foal that's trying to nurse.
So we just have 20 minutes to talk a little bit about eyeballs and foals. And with that being said, you guys, I mean, given the stuff that we've seen today and what you guys see in your daily life, you know, working with horses, I'm sure you'll probably be fine with everything I'm going to show. But that being said, some people do not like eyes. And so this is all about eyeballs. So if you get squeamish around eyes, there are going to be diseased eyeballs coming up on the screen. So feel free to step out. I don't do people. I don't know if anyone else in here does. So, you know, just take care of yourself. Okay. So first I thought, if I can get this to advance, that we would just talk a little bit about anatomy, just so we're all talking about the same things. This is a diagram of an eye, right? Kind of cut in half. So we have the eyelids, upper and lower eyelids. We have the third eyelid, right? Which we know dogs, cats, horses, cows, they all have those. And they can kind of come up and cover part of the eyelid or the eyeball. You know, and if you don't know what that is, you might say like there's something foreign in a horse's eye. Conjunctiva that comes on the bottom of the eyelids and then around covering the sclera or the white part of the eye. It's pink normally and usually very, very thin. So a horse's sclera can be white, can be pigmented or kind of spotty. That's normal. And the conjunctiva is usually not really visible until it's inflamed, which we'll see in some pictures. And then we've got the cornea, right? The clear part. That's kind of the windshield of the eyeball. Between the cornea and the iris is the anterior chamber. There's just some liquid in there, basically fluid. The iris is the colored part of the eye, right? So if you have blue eyes, you have a blue iris. Same with a horse. Most of them have brown irises, right? But sometimes they can be blue. And then in the middle of the iris is the pupil that we look through. Directly behind the iris, kind of through the pupil, is the lens. And that's the focusing part of the eye, right? So if we're talking about cataracts, which we'll talk a little bit about, those are in the lens. And they're basically opacities of the lens. Behind the lens is the posterior chamber. It has kind of jelly material in it. And then the very back of the eye is the retina that has those fancy specialized cells that basically interprets light and shapes and sends that information up the optic nerve to the brain, which is how we and animals see anything, which is pretty cool. So translating that to a horse eye, this is not a foal, this is an adult horse, but I think a good image of a normal eye. So obviously we have upper eyelid, lower eyelid, third eyelid in this horse. The leading edge or the edge of it is pigmented. Sometimes it's pink in paints and non-pigmented horses. Brown iris, pupil here in the center, corpora nigra, which is kind of the sunshade that covers over the top of the pupil. It's pretty fancy. They have their own like visors in their eyeballs. And a difference between a newborn foal and an adult horse's eye, probably the biggest difference is the shape of the pupil. So in a foal, a newborn foal, it'll be round. And then over 5 days-ish, it'll kind of change to this oval shape. And then the cornea, obviously we can't see in this picture because we're looking through it. It's clear, it's normal. We have a couple artifacts here with some light reflecting off the cornea and then reflecting off the lens here. So normal eyeball. So signs of an eye problem in the foal are going to be pretty much the same as an adult horse. So we'll just briefly go through them. Squinting or holding the eye shut. We will talk a little bit later, but I'll mention it here. Systemically sick foals, weak foals, are going to be way less likely to show you that they have an eye problem. So if they're weak in general, they might not, it might not be as obvious that they have an eye problem. Swollen eyelids, tearing. Clearly this horse has a lot of tears happening and a lot of kind of goo from conjunctivitis in this eye. And then, so this is a great image of some really angry conjunctiva and sclera. And so you can see all this pink, you know, kind of red, right, from inflammation. You can see the conjunctiva over the sclera here. This horse has a blue iris. And so you can see really well these vessels that are actually on the cornea reacting to all the inflammation in this horse's eye. Excuse me. This is like a little like sneak peek. So we also have some hemorrhage in the iris here. And then this yellow staining, I said that this horse has a blue eye, but it doesn't look blue, right? It looks yellow. And that's from serum staining because of all the inflammation, those blood vessels get leaky. And so stains things. So I don't have, this isn't a uveitis talk, so I don't have the before and after. This is the before, but after some treatment and calming down that inflammation, that horse did have a blue eye again, which was nice. So a cloudy cornea, I mean, as we're talking about all these things, all of this is really color change, right? So more red than it should be, more white than it should be, could be blue, could be yellow, could be green. So those color changes are really important. Is this normal or abnormal? You know, we're looking at color. So cloudy cornea, all of these horses have different problems, but they all have a cloudy cornea as part of it. Another sign of an eye problem can be blood inside the eye. So blunt force trauma is often the cause of this, but in foals, it can be from septicemia. So if they're systemically sick and they have bacteria, you know, infecting kind of their whole body, it can present as hyphema. So it can be a little window. Other signs of an eye problem. So this is a cataract. This is a hypermature cataract in a older horse that has ERU, but it's complete opacity of that lens. And so whether it's a congenital cataract that we can see in foals or this kind of end stage uveitis caused cataract, that horse can't see through that. They can probably see light and dark, depending if their retina is still working. But if you can't see through the lens, they can't see through it out either, as far as shapes and things. Vision loss can be really difficult to determine in a horse, and probably particularly a foal, because they kind of are hyperreactive a lot of times right in the really early, like neonatal period. And especially if we maybe have a little maladaption, maybe a little bit, you know, hypoxemia or a dummy foal situation. Is it because they can't see because their brain is affected because they're a dummy foal, or do they have a primary eye problem? And so that can be something just to sort through. And then eyelid lacerations, of course, there's nothing particular about a foal's eyelid. They can get cut just like an adult's eyelid. And as I kind of alluded to, foals are sometimes different than adult horses as far as just not displaying a lot of obvious signs of discomfort if they are systemically sick. So they might not show you the squinting, the tearing, et cetera. And so color changes become even more important in these guys. So some specific eye disorders of the foal, they're I put them in kind of three overarching buckets, if you will, or categories. So there's congenital abnormalities, and we'll go over these a little bit in the next couple slides. Congenital abnormalities, inflammation or systemic illness, and how that can show up in an eye, and then trauma. Underneath that umbrella, I kind of categorized corneal ulcer, eyelid laceration, and blunt trauma. So for congenital abnormalities, I put breed associated, and I probably should have just taken that out and just put inherited, because this multiple congenital ocular abnormalities syndrome, or MCOA syndrome, has been found in lots of different breeds. We do know that it's inherited. It's a genetically affected, I guess, or linked disease. And it is associated with silver color. So that silver dilution is connected with this eye problem, unfortunately. So you can, excuse me, you can test for it. So UC Davis has a test. It's another test that we're looking at a bunch of roots of hairs. So it's, you know, you can add it into, if you're testing other things, you can test for this. If it's a breed that you are, that sometimes is affected with silver colors, even if you're not shooting for that, you know, they don't have to be silver to have the disease. And like I said, there's lots of different breeds that are affected. We kind of classically think of Rocky Mountain horses, but on UC Davis's website, they have probably 25 different breeds that can be affected with this. And signs that you'll see include cataract, include iris problems like thin areas or cysts or holes in the iris. And then some retinal problems that could certainly affect vision. And then I guess I should say, you guys probably all know, but congenital just means they're born with it, right? So that's what the term congenital abnormalities mean. So then as far as, you know, either not inherited, or we don't know if there's a genetic component to them. Congenital cataracts, microphthalmia, which microphthalmia is basically just born with really small eyes that are underdeveloped, that didn't form correctly in utero. And then entropion is that's what's pictured here. So the lower eyelid is basically kind of curled in, and the eyelashes and the hairs of that eyelid skin can rub on the cornea and cause corneal ulcers and secondary problems. And this can be something that might need surgery to be corrected, but certainly in a super young neonatal foal that has this, they might just be a little dehydrated, and you might just need to give them some time. There are things that your veterinarian can do to temporarily evert that, or roll it out, that eyelid, so that it's not rubbing on the cornea, causing other problems while that foal is kind of growing into their eyelids, if you will, or getting rehydrated, which obviously you would want to be addressing as well. So inflammation, uveitis is just inflammation of a certain part of the inside of the eye. You may have heard the term uveitis in conjunction with equine recurrent uveitis, or ERU, or moon blindness, and that's not what we're talking about here. We don't see ERU in foals. So in this situation, it's simply inflammation of the inside of the eye, and in foals, it's most likely caused by some sort of systemic condition. So septicemia, rhodococcus, for example, can present as either uveitis, like in this picture, with a cloudy cornea. There are some white blood cells kind of settling down at the bottom of that anterior chamber, really small pupil, painful, if the foal will show you that it's painful, and also that hyphema, or that blood in that inside of the eye, can be a presentation of this as well. And then trauma, another situation that I guess is under this trauma category is a scleral bruise or scleral hemorrhage that simply, I mean, we have talked this morning a lot about how foaling is a traumatic experience, right? Not just for the mom, right, and for the mare, but also for the foal. So there's a lot of pressure that can happen on their eyes, and so they can get bruised, basically. And so that would be redness on the outside, on that sclera, that white part of the eye, and that generally goes away in 7 to 10 days, just like any other kind of bruise would resolve. And so that's not generally a big issue, but something that you might see. And then corneal ulcer, similar to an adult's eye, right? They can get scratched, whether it's from that entropion or from something they ran into in the stall, or hay straw that they laid on, et cetera. And so this bright green spot here, that is fluorescein stain. So you put fluorescein in the eye, you'll see it kind of settles down at the bottom, so just in the tears, and it gets spread across the surface of the cornea, and it doesn't stick to normal cornea, right? So wherever that dye sticks, that means there's basically a wound on that cornea. There's a break in that epithelium, that covering of the cornea. And certainly it can get infected. That's kind of worst case scenario. And on the next slide, or next couple slides, I think we have pictures of infected cornea. And then eyelid lacerations and blunt trauma kind of speak for themselves, I think. So a superficial corneal ulcer, this is probably the most common problem that we see in horses in general, not just foals, when it comes to their eyes. Generally not a long-term treatment, generally a pretty straightforward treatment. And goals here is to prevent infection. So a simple superficial corneal ulcer, by definition, is one that's not infected. We want to keep it that way. So infection can really move very quickly through the cornea. It's not very thick. And so we want to make sure that we're proactive. Eyes are, if there's a problem with an eye, call your vet right away, because things can move pretty quickly and we don't want to wait and give it time. And then, of course, we want to control pain and inflammation as much as we can, both for the welfare of the horse and to hopefully keep them from rubbing their eye and causing another problem. So this is a picture of a foal that I saw for squinting. And you can see the fluorescein stain, right? Just in this whole kind of lateral outside part of the cornea, and super red conjunctiva, right?
And luckily, this was a pretty straightforward diagnosis, not only of the cornea, but also the cause. And so I plucked that little plant material that was wedged where that star is on that picture. It had just punctured really right into the conjunctiva and was stuck there. So I had to kind of use some force to get it out. It wasn't just going to fall out on its own. And so every time that foal blinked, it was just scraping against his cornea. So he felt a lot better once we got that little plant piece out. So this is what we're trying to prevent, or two examples of what we're trying to prevent. These are both adult eyes, but it could easily be a full eye that could look the same. So an infected corneal ulcer can be infected with bacteria or fungus. The Southeast United States, we think more of fungus, but you can certainly see fungal infections anywhere in the country. And so in this situation, we're no longer trying to prevent infection because we already have infection, unfortunately. And so now we're trying to treat it. And basically we're in kind of a race between treating it, killing the infection before it has a chance to kind of eat through the cornea. And worst case scenario could cause rupture of the eye. So unfortunately, that's what happened with this case on the right. That's a really, really deep ulcer that basically has, in some areas along the edge, just one layer of cells left. And unfortunately, we ended up taking that eye out. But so quick evaluation and initiation of treatment is super important. We're talking about young foals, young horses just starting their life. We, of course, want them to maintain their vision and their eyes for their life. So eyelid lacerations, I'm not going to spend much time on this at all. I want to keep us on time. But just like in any each horse, right? You want to repair them as soon as you can. And like I mentioned, we're trying to set this foal up for a healthy, long life with intact eyes. And that eyelid margin is super important for protecting the eyeball, right? But also dispersing tears normally over the surface of the eye. And so if there's an abnormal eyelid margin, then it can set us up for corneal disease long-term. So really important to address those quickly. So take-home points, eye problems in a foal can alert us to a systemic disease, really more so than an adult horse. Prompt examination and treatment makes a big difference in eye problems in general. And then when in doubt, call your veterinarian. Yes. Yeah. So the question was what moon blindness is. So it doesn't affect foals, which is why I kind of cruised over it. But equine recurrent uveitis is an autoimmune disorder where basically the immune system recognizes the eyeball as foreign and so starts to basically attack the eye, which causes a lot of inflammation that comes and goes. So that's where the recurrent comes in. And moon blindness is because back in the day, before we knew a lot, the waxing and waning was kind of attributed to the moon because that waxes and wanes. And so it certainly can cause vision loss and pain in horses. So does that answer your question?
Yes.
Yeah.
All right, everyone. Hi, I'm Jessie Tima. I'm a surgeon and I'm really excited to join the Rhinebeck equine practice. I know that I'm a new face to all of you and I look forward to getting to know all of you, hopefully not on an emergency basis off the bat, but we'll be there if needed. I wanted to spend a few minutes just to give you a brief overview of my background and what brings me here to Rhinebeck Equine and here today with you all at this symposium. I grew up in Bucks County, Pennsylvania, so this dot right here. I grew up riding hunter jumpers. I love horses from a young age. I went on and did my undergraduate work at Amherst College and then vet school at Cornell. After Cornell, I was lucky enough to get an internship at Rhinebeck Equine, where I spent a year learning with the team here. That was from 2014 to 2015. So I may have met some of you in the intern role at that time. I went from Rhinebeck down to the University of Georgia for my surgery residency. And following my surgery residency, I joined a private practice very close to home. I moved to Hunterdon County, New Jersey, and I've been there for the past 3.5 years, practicing large private practice referral center. In that time, I've gotten to work with both a large standardbred and thoroughbred breeding population and racing population. I've gotten to work with these animals from a really young age in the foals, working on septic joints and physes, a little bit older, managing their angular limb deformities, older yet, preparing them for sales, managing OCDs, onto their 2-year-old year, breezing and looking at some buckshins. And then some of our racehorse surgical problems as well, carpal slab fractures, sesamoid fractures, condylar fractures, and working with some of these horses, not only in their racing careers, but then also transitioning them to their next career following racing. It's been a really rewarding experience, and I look forward to bringing this experience forward to the Rhinebeck Equine team here. So back to what we're talking about today, joint ill and why this is important to all of you. This is both a debilitating and life-threatening disease to our foals. It can cause permanent joint and or growth plate damage, and it affects foals from birth, can affect them all the way up until weaning. So really a wide age range there. I'm going to spend a moment here to go over a little bit of anatomy to contextualize how and why this happens and why it's important. So a joint is going to be in between two bones here. Each end of the bone is covered with articular cartilage. That's that blue line here. And it's surrounded by a synovial environment. That synovial environment is the joint itself. The joint is lined by a synovial membrane. That's the red here on each side. And that is what produces the joint fluid that keeps the joint environment healthy. The growth plate is this line that sits here a little bit above the joint. There's one down here as well. Each bone has one. The epiphysis is the bone that sits in between the growth plate and the joint, and the metaphysis is the bone that sits further away from the joint from the growth plate. Overall, what is joint ill? The veterinary terminology here is septic synovitis or arthritis. Synovitis refers to septic or an infectious process in the synovial cavity, so the joint itself. Arthritis is more specific to the joint than just the synovial lining. They're somewhat interchangeable, and I will use all of these terms interchangeably throughout. And then joint ill is where we have massive inflammation of these structures as a result of infection that is spread through the bloodstream. Bacteria travel through the bloodstream, normally seeded through other body systems. And this is one thing that distinguishes septic joints and septic arthritis from in the foal from our adult population, where we more often see that because of a traumatic event or sometimes an iatrogenic event, which means that we have done something that has actually introduced that bacteria. Not as common. When we talk about our foals, it's almost invariably through their bloodstream that this is happening. So how does this occur? Some predisposing factors are going to be failure of passive transfer, respiratory infection, umbilical infection, or gastrointestinal infection and translocation through the gut. And that bacteria is then going to enter the bloodstream and then seed into the synovium, which is the joint lining, seed into the growth plate or the physis, and then the metaphysis and the epiphysis, which is the bone on either side of the growth plate. From there, we're going to have massive inflammation and degradation of that joint environment and a true septic process where bacteria has set up in there and starts to take over that joint environment and destroy all those structures that we talked about. There's generally two manifestations of this disease with an age divide around 3 weeks or so. Those foals that are younger than 3 weeks oftentimes have infection in multiple sites, and those infections are typically in the synovial environment, so limited to the joint itself or in the epiphyseal bone, so the bone that sits between the joint and the growth plate. In our older foals, so 3 weeks and older, we're looking at typically only one joint or growth plate infected, and that infection is typically at the level of the growth plate or from the growth plate heading up towards the middle of the bone and away from the joint. These aren't hard and fast rules, but they are generalizations of patterns that are commonly seen. Clinical signs that you may have joint ill include swelling of a joint. So effusion is the veterinary terminology for there being increased fluid inside of the joint itself. So that joint is big, it's turgid. You're also going to have heat, and you're going to have pain on palpation or pain on passive flexion. So if you say have a foal with an effusive or swollen hock and you ask them to flex it, they're going to resent that because there's so much fluid in it. It's really painful for them to do so. Oftentimes they're going to be quite lame, but there are certain sites that don't necessarily make them as lame as you would think that they should be. And a lot of times these foals are going to have fevers as well. So these are all things to watch for in your foal populations. This is just a video exemplifying the degree of lameness that we can see. This is a foal that's in a hospitalized environment, so actually already under treatment, but can see on that left hind limb, which is bandaged, just how sore this foal is and unable to get around. It's quite debilitating. If you see these signs in your foals, prompt veterinary evaluation is really important. It's important that the foal gets assessed because it's going to ultimately affect what the outcome is going to be and what that prognosis is going to be, both for survival and for athletic performance. I'm going to talk about each of these diagnostics here more in depth, but just to run through in general what we're going to do, any foal exam is always going to start with a comprehensive physical exam. So looking at the foal from head to tail, we will get to the joint or the site that's affected, but we need to look at the whole foal and not just the affected joint. We're going to get a sample of that joint, a joint tap, and perform an analysis on the fluid that we obtain from that sample. And we're going to learn a lot from that, both at that time that we're looking at it when we get the sample, and then when we send out for culture and susceptibility as well, to find out what might be growing in there. We're going to perform generalized blood work, a CBC and a chemistry likely, and we're also going to measure some inflammatory markers that can help us guide treatment going forward if we repeat those measures and see what the response to treatment is. We're going to perform x-rays of the affected site. We're going to ultrasound likely the affected joint itself, and then also the umbilical structures and the thorax, because like I mentioned earlier on, oftentimes these foals have disease in other systems, and it's important that we're treating everything when we come up with our therapeutic plan for these guys. So starting with that joint tap, this image is actually in an adult, but I think it illustrates well aseptically placing a needle into the joint space here between, this is two bones in the carpus. What we're going to be looking at here initially is what the gross appearance of the joint fluid is. Normal joint fluid is clear to straw colored, and it has a really nice viscosity in it to it. Infected joint fluid does not look like that at all. It can have a variety of different colors. Oftentimes it's bloody, orange, it's cloudy, it's opaque, and it actually loses that viscosity. It's much thinner because of the degradation of that joint fluid by all of the inflammation that's going on from the disease process. We're then going to take that sample to the lab, and we are going to run a bunch of tests. We're going to start with a total nucleated cell count. That's going to tell us how many inflammatory cells are in that joint environment. Normal joint fluid has very few inflammatory cells in it. So anytime that number is increased, there's at least inflammation, if not infection. I'm putting greater than 10 to 30,000 cells per microliter here. I know that's a big range. Some of the context clues with the other things that we're looking at are going to tell us whether or not that is septic. There are different reports that say different cutoffs. So I think it all has to be taken contextually here. We're going to be looking not only at how many cells are there, but also the type of cells. So the neutrophils are the first, or the type of inflammatory cell that are going to show up first for an infection to try and clean up. So they're going to try and eat the bacteria that are in there. So if we have a lot of neutrophils in that joint environment, that's going to be concerning that there's a lot of bacteria causing a lot of inflammation, and the body is sending a lot of neutrophils there to be able to take care of that. And these are two cytology slides here showing both septic joints. Sometimes we're going to see bacteria that's sitting outside of cells and relatively normal looking inflammatory cells. This just looks like mush because there's so much degradation of the cells by the bacteria, which are actually in the cells now. So the cells have tried to consume the bacteria, and all of the toxins in the bacteria are now basically destroying the cells secondarily. We're going to be looking at the total protein. Normally in healthy joint fluid, that's going to be less than 2 to 2.5. So when that's elevated, it's something else that supports that joint could be septic. We're going to take a sample of that joint fluid that we've aspirated, and we're going to put it in a blood culture vial in addition to the foal's blood as well. This is going to give us growth in about 86% of samples in this vial specifically. Some of the common things that we're growing are, I put a list of bacteria here. In general, these are things that are going to be in the environment, things that are going to be in the feces, and things that grow in normal skin as well. We're going to perform radiographs on the affected area or areas. What we are looking for here is there any bone involvement? Foals with septic joints much more commonly have bone involvement than adults because of the nature of the disease. What is important to note, though, is that when the infection shows up, even if there is bone involvement, that bone involvement might not be radiographically apparent or visible on x-rays for up to 21 days after the infection. So not only are we going to take x-rays off the bat, we're likely going to monitor x-rays over the course of the disease. So some of the images here illustrate what we're looking at. This is a hawk, and we're looking at this lateral trochlear ridge and this black area right here, that's showing loss of bone density because of disease. Here we're looking at a medial malleolus and just loss of bone and then some abnormal bone there. And there's loss of bone density here in this medial femoral condyle as well. This image is taken right out of a recent paper, and it is just a way to show what the changes on x-rays actually translate to when you're looking inside the joint itself. So in the middle, we have an x-ray. This is a slice from a CT or computed tomography, which is essentially just a three-dimensional x-ray. And then this is a postmortem sample. So here we can see bone loss in this corner on the medial condyle. We can also see that compared to over here where we have nice joint space, there's not as much joint space over here. What the CT shows us is how much of this bone that's right at the joint level, so the subchondral bone, is actually lost. And then when that joint is open post-mortem, there's a huge ulcerative lesion here on the condyle. There's an ulcerative lesion on P1 that matches that. And looking at the nature of the cartilage over here, it's white and shiny. It's all thinned around here as well. So it just tells you what's going on in the joint itself when we see these small changes on x-rays. We'll oftentimes use ultrasound on the joint, on the physis, growth plate, to assess as well. Some of the things that we'll be looking for are inside of the joint capsule. What is the nature of the fluid? So here we're looking at two hips, the left hip being the affected hip, the right hip being normal. This is the joint capsule extending around here versus this joint capsule here. This joint capsule is distended. There's effusion in the joint, and a hip joint is not one that we can see on physical exam that it's necessarily effusive. So this is really helpful. And there's an increased, here we're seeing that the joint fluid is more black. Here there's more gray in here, which is telling us that there's increased cellularity in that joint. This ultrasound is showing a physis. And bone is this bright white line here, but a physis should be a relatively flat line to a relatively flat line with a space in between. Here we actually have this black is actually fluid because there's an abscess here, and this is abnormal bone growth because of the infection that's going on. We're going to transition from diagnostics to treatment. So the tenets of treatment for any kind of joint ill are going to be local lavage and antimicrobial therapy. There are many different manifestations of those two, but those are the two basic things that we need to accomplish. For local lavage, we're typically talking about a needle flush or an arthroscopy in order to flush out all the bacteria and inflammatory mediators in that joint. And for antimicrobial therapy, we're going to break that down into two separate categories. We're going to have systemic antibiotics that we're giving to the foal. Usually those are going to be intravenous off the bat. They may transition to oral, but essentially that's delivering antibiotic to the whole body versus local antibiotics, which are going to be directly into the area that's affected. When we're admitting a foal and making our initial treatment plan, our systemic antibiotics are typically going to be broad spectrum to start, but we will ultimately make that decision as the treatment plan continues based on culture and sensitivity. And for local antibiotics, oftentimes we'll choose an aminoglycoside as our first line of treatment, depending on some other systemic parameters of the foal, if that's appropriate choice. And then again, transition that decision based on culture and susceptibility. This picture here is just of a plate showing the susceptibility patterns. So it's something that we can do in hospital. And what this is showing is just how much bacteria growth is inhibited by these little antibiotic discs. So moving on to the joint flush, the big saying here is dilution is the solution to pollution. So like I mentioned before, we are removing bacteria and inflammatory mediators with this treatment. We are putting usually 2, 3, 4 needles into this joint. We get the sample and then we are pressurizing fluid bags to run through these different needles. Many joints have different access points in order to flush out the cavity as thoroughly as possible. At the end, we'll leave 1 needle in and we'll deposit antibiotic, bandage the limb, and then that treatment is typically done for that treatment period. Arthroscopy is when we are, I'll back up a second step here. This is typically done under just a brief anesthetic, oftentimes stall side. So the joint itself is sterile, but you're not in the OR for this. This is done routinely stall side. Versus arthroscopy, this is putting the foal in a complete aseptic preparation for the joint that's affected, typically in the operating room. When we're reaching for this is if we're doing our assessment and there are bony abnormalities of the joint off the bat. If you have a foal that's admitted and you've been managing them with the needle lavage and you're just not getting the response that you would hope or expect at that point, if that were truly affected, you may need to go do the arthroscopy. When the condition is chronic, so the foal is coming in and this has been going on for longer than it should have been before evaluation, you almost want to have an idea of going in there with a small camera into the joint to see what's going on, to be more aggressive with the management and probably prognosticate. And when fibrin or debris are present. So fibrin is a byproduct of inflammation and infection. It is going to lay down this thick yellow gelatinous surface on the inside of the joint. Needle lavage is probably not going to remove this. We will need to take manual or motorized instrumentation in there in order to manage this. But to explain some of these pictures a little bit better, this is showing that arthroscope or the small camera going in just through a keyhole incision and visualizing that joint surface. And these are some images that camera is taking. This is showing a small abscess on a medial malleolus here. And this is showing an instrument that's able to drop into that and then debride that area away of that infected bone. And like I mentioned, this is an image of fibrin sitting inside of a joint that likely would be not adequately responsive to needle lavage. Another tenet of our treatment is going to be our local antimicrobials. There are many different ways to do this, and it'll depend a little bit of the nuances of the specific disease process that's going on. I've already mentioned intra-articular injection, and that's where we're putting a needle into a joint and injecting antibiotic right in. Oftentimes that's going to be pretty routine following needle lavage itself. A regional limb perfusion is what's pictured here. So we'll isolate a region of the musculoskeletal system with tourniquets, which is going to prevent blood flow back to the center of the body. And we are going to inject an antibiotic here slowly into a vessel, and that antibiotic will perfuse into the local tissues. Here we're isolated in the hock area between these two tourniquets. There's going to be both a concentration and a pressure gradient. For our younger foals specifically, this is shown in an adult here. This will likely be done under a brief anesthetic as well, because keeping them still during this is important to be able to keep these tourniquets relatively effective to get that gradient into the tissues. An intraosseous injection or perfusion. So the perfusion is the same idea as a regional limb perfusion, except that you're infusing right into bone itself with a large bore catheter, versus an intraosseous injection is taking a needle into a bone and depositing antibiotic once, not necessarily under pressure. That's probably most appropriate for our growth plate infections. Following arthroscopy, we can actually leave a small catheter behind in the joint itself, and that'll allow us to deliver repeated antibiotic without having to introduce another needle in, or we can hook up a CRI pump, CRI meaning continuous rate infusion. So there's a constant infusion of antibiotics into that space over time to help with treatment. Physeal debridement, here, this is an instrument, a little curette reaching right into the growth plate itself to debride an abscess that was there. This is something that we need to be judicious about, because it's important that we get away any infected bone and are able to clean that out, but we don't want to disrupt growth as well. So this isn't something we're oftentimes reaching for right off the bat. This case was actually that ultrasound image that I showed a few slides back where there was that abscess sitting right at the growth plate. Arthrotomy is the fancy surgical term for putting a larger hole into the joints. This is going to be much bigger than the small keyhole incision that I had mentioned earlier for arthroscopy. This is truly a salvage procedure. And what you can see in this picture, this is actually a video. It's pretty graphic. I don't know how everyone feels about pus, but essentially there was just such a large volume of very thick pus inside of this joint, and the incision had to be a certain size in order to milk that out. And I do say that this is truly salvage, because if the disease has progressed to that point, it's unlikely that that joint environment is going to recover. But this does have a wow factor too, so that's why I included it here. Happy to show that video if anyone wants to see it, but it's a lot to watch. So as much as I like to talk about bones and joints, we need to think about our whole foal here. So these foals are going to be painful on these joints. There's a lot of inflammation going on. So they're going to need to be on anti-inflammatories, likely gastroprotectants, and also probiotics for support while they're on a breadth of antibiotics in the hospital environment. So we've gone through all of the nuts and bolts of all of it, but what does it look like in practice? So what to expect if you have a foal that you suspect may have a septic joint, it's coming into the hospital for evaluation, what can you expect? Like I mentioned to start, we're gonna begin with just a generalized physical exam, make sure to get a sense of if we have any other concerns about other body systems before proceeding with the rest of our plan. Then most of what we're going to do is actually going to be under that brief general anesthetic that we will give just as far as restraint goes and being able to get things done efficiently and effectively for the foal. We're going to collect blood, and we're going to perform some of that point of care blood work that I talked about, and also get that aseptic sample to send off for blood culture to see if the foal is septic and we do have bacteria running through the bloodstream that could be seeding other areas as well. We're going to get an intravenous catheter into the foal. Then we're going to perform our diagnostic imaging. So x-rays of any clinically affected joints. So whatever they're presenting for. And in our physical exam, we're going to get an idea of, are there other areas that may be suspect as well, that while we're doing this, let's image those too. We're going to likely ultrasound the joint, get an idea of what that joint fluid looks like, or get an idea of what that growth plate looks like. And then something else that's really important is that we're ultrasounding our umbilical structures and our thorax as well. Again, we need to think about the whole foal, and these disease processes don't happen in isolation. So we need to see if there's anything else that we need to be concerned of or treat, and also how that's going to affect our prognosis. We're going to get a sample of the joint fluid. The fancy word for that is an arthrocentesis, perform that synovial fluid analysis, and send off a sample for culture. We're going to lavage that joint, still under this brief general anesthetic episode. We're going to make an empirical choice for an antibiotic that we're going to put in that joint, bandage the joint or the limb, depending on the level of what's affected. And then from all of the information that we've gathered from this point to this point, we're going to establish a treatment plan going forward. After the initial treatment, we are going to be monitoring progress over time. So things that we're going to be looking for is the lameness getting better? If the foal had a fever, have the fevers resolved? If the foal did not have a fever, does it have a fever now? We're going to be repeating our x-rays, and we're going to be looking for any bony change. Like I mentioned, there may not be bony change when we're initially evaluating these foals, but there may be over time, and that's going to help guide perhaps a change in treatment plan to something more aggressive, and help us prognosticate how good of a job we are doing at tackling this issue. This is, again, another extreme example that I'm showing here, but I think it illustrates a point. These radiographs are taken 5 days apart, and you can see this is the epiphyseal bone, so the bone between the joint and the growth plate, and you can see that there is some, it looks a little bit more mosaic-y than it should. But then if you come over here 5 days later, you can see how much bone loss has occurred. So really poor prognostic indicator in this case here, but those radiographs were really helpful in being able to establish that. We'll also be repeating our joint tap and that fluid analysis. We're looking for that total cell count to be coming down from wherever we started. We want to see that come down pretty dramatically. And we also want to see the percentage of neutrophils, which I said those are kind of the red flag inflammatory cell. We want to see that percentage coming down, because what that means is that that joint is starting to recover from the inflammation specifically due to infection. When we're deciding how long to continue treatment, it's really important for us and you all to remember that lameness resolves before infection resolves. So just because the foal is sound and the foal is afebrile, that doesn't mean that we just cut treatment off right there. A little bit of two different scenarios here. When our problem is isolated to the joint itself, so those septic arthritis and synovitis, typically those younger foals, when that repeat joint cytology shows that the total cells have come down and there's less than 80% of those neutrophils in that sample, we're probably going to, around that time, stop the local lavage and local antibiotics. We're going to keep up with our systemic antibiotics for at least 2 weeks beyond the resolution of clinical signs. Oftentimes at that point, it's going to look like, as we have our culture back, we're going to find an appropriate antibiotic that foal oftentimes can go home on if it's stable otherwise. When we're talking about growth plate or bone involvement, so septic fasciitis or osteomyelitis, we are likely going to continue our local antimicrobials for about a week after the resolution of clinical signs, so longer than here. And we're not necessarily getting a joint sample here because joint isn't necessarily involved. Then our systemic antimicrobials, we're going to extend out possibly a little bit longer. So expect 2 to 4 weeks of antimicrobials after all clinical signs have abated. And that's just because the bone infections are just harder to treat, harder for the antibiotics to penetrate, and harder to recover from. So we support them for longer. Sending a foal home from the hospital. This is just a brief overview of what instructions will look like. The foals are going to go home on medications, including antibiotics, an NSAID to help with pain management, oftentimes a probiotic and a gastroprotectant. They're going to be initially stall restricted until we are certain that they're thriving and doing well at home. And we've transitioned down care. They've gone through a clinical recheck before giving the thumbs up for more exercise, because we don't want them to be exercising on a joint that's significantly inflamed. There may be bandaging to do depending on the level of the affected joint. And then usually we're recommending a follow-up examination either with whoever's seen a primary care veterinarian or follow-up from the hospital itself with a clinical exam, repeat radiographs, either to see if we're seeing improvement where there was a change on the x-rays before, or just to document that there has not been any negative change since the last check. We'll be likely doing some blood work, both to look at CBC for overall systemic health, and then fibrinogen is one of the inflammatory markers that I mentioned as well. We may be ultrasounding the umbilical remnants or the thorax. And again, this is looking at the full foal and was there any evidence of disease there prior. In these discharge statements, we're going to be recommending that you be monitoring for any increased lameness, swelling, heat, difficulty rising, the same things that you were watching for before the foal came up with the septic joint in the first place. Any increased temperature exceeding 101.5, watching their umbilicus for any increased size, drainage, or heat, keeping an eye on their appetite and their urination, and the size and consistency of the mare's udder as well to ensure that they're nursing. I'm going to spend a couple minutes to talk about our prognosis. There are a lot of papers out there with a lot of variable information. I tried to sum that up. Overall, I'm going to say prognosis for survival is good with an asterisk. The asterisk is that we're seeing these foals acutely. So getting to that point where we're diagnosing and managing them pretty quickly after the onset of signs, that they don't have significant comorbidities. And what comorbidities means are disease in other body systems. And the literature that's out there says that 42 to 80% are going to survive. The 42% is typically older papers. They're trending up. The more recent literature is definitely trending up. Things that are going to increase the chance of survival include foals that present with clinical signs that have been going on for less than a day. When we're talking about aggressive and multimodal treatment. And what I mean by that is all the things that I've talked about already, not only doing systemic antibiotics, but doing local antibiotics, doing different modalities of local antibiotics, essentially trying to get after this bacteria as many different ways as we can so that we can get ahead of it. And then there's one report that says that continuous synovial infusion, so that putting that CRI pump in after an arthroscopy is going to increase their chances for survival. Things that are going to decrease their chance of survival are specifically the involvement of the epiphysis, or the bone that sits between the joint and the growth plate itself. That those foals tend to not do as well than foals that just have a septic joint, just have a septic physis. In general, bone involvement tends towards the negative already, but specifically the epiphysis is an area they're going to struggle with, because that's the bone plate that's going to sit underneath the joint as it develops. Multisystemic disease, again, I've already touched on this a few times. So disease in other body systems, if they're septic, if they have pneumonia, if they have septic umbilical structures, if they have a gastrointestinal issues as well, all of those things are going to translate to a worse prognosis. And then specifically if salmonella is the bacteria that is isolated, either in the bloodstream or from joint fluid, those are negative prognostic indicators. When we talk about athleticism, overall, I'd say the reports are more mixed than for survival. Things that are going to influence are ultimately things I've already mentioned here. So the presence of systemic sepsis and multisystemic disease, multisystem disease, the number of joints that are involved, which is something I haven't really touched on yet. If there's a fewer joints that are involved, typically the better the prognosis. The presence of greater than 95% neutrophils in joint fluid at admission. I've mentioned this a couple of times. Someone doing a paper found this as a cutoff level, saying that if there are more than 95% of these specific type of inflammatory cells in that initial fluid, that is going to be a negative prognostic indicator for athleticism, specifically for thoroughbred racing. Prompt initiation of treatment and the presence of osteomyelitis or bone infection, all of those things are going to affect whether or not, by the literature, these foals are going to go on to race. Specifically, there's some positive news though here. One report that's just isolated to thoroughbred says that there's no difference in the mean sales price, or the percentage of these foals that ultimately get sold at the weanling, yearling, or 2-year-old sales, compared to controls. Whereas another paper says that these foals in general are less likely to start, and it takes them longer to reach the first start, but there isn't too significant of a drop off. So out of a control population, if 66% of thoroughbred foals that don't have disease are going to reach their first start, only 48% of those that have had joint ill are going to get to that point. Another paper that looks at both standardbreds and thoroughbreds together says that 79% survive to discharge, which is quite a good rate to discharge compared to some of the other, the range that I gave earlier, but only a third of those race. So that's a big drop off. And I think what this tells me is that what happened between discharge and the next few weeks at home there makes me question that. So the take home points, I want to reiterate that a lame foal is an absolute emergency and should be seen ASAP to get appropriate treatment started, because ultimately that's going to affect your prognosis both for survival and for athleticism. This is a distinct disease process from septic joints in adults. I mentioned that at the beginning. So we have to think about it differently, and we treat it a little bit differently too. The prognosis is ultimately dependent upon the rapidity of the diagnosis and initiation of appropriate treatment and the presence of any comorbidities, so disease in other body systems. Overall, prognosis good for survival when the infection is limited to just the joint itself, but there's mixed reports for athletic prognosis overall. So here are some references, and with that, I'm happy to entertain any questions.
You mentioned that it takes about 21 days to see bony change.
It can.
Is that the same? Is that for foals or is that for adults?
For foals specifically, for foals, yeah. Adults, it's not, the pattern is just different in adults. Adults, it's much less common to have bony change in adults in general. And that's because of the way that the blood vessels are regressing as foals mature in that very early stage of life. Yeah. Oh, yes. The question was regarding 21 days to be able to see bony changes on x-rays. Yes.
Do you employ the use of stem cell therapy?
Typically not for sepsis, because what I don't want to do is give bacteria another medium to grow upon. I think when we talk about stem cell therapy, there's a lot of we probably have more questions than answers. And I think stem cells do have their place with joint therapy, but sepsis is probably not a place that I would reach for them because I would worry that I'm doing more harm than good. What I want to do is really use the tools that I can to get the infection and inflammation under control. And if we have some deterioration of that joint that we know is going to be a chronic problem, then far after the resolution of the infection would be a time that we could consider using stem cells as an adjunctive therapy to maximize that joint's potential and health.
So when a foal presents to you with swollen joints,
Mhm.
Depending on the age, what do you suspect initially?
It's joint sepsis, no question. Yeah, if a swollen joint in a foal is a septic joint until proven otherwise.
Even in the early stages when they're still.
In the early stages, I mean, so you're talking like just after birth?
Yeah.
Just after birth, I think, in the first week, you start to get into a gray area. Immediately after birth, there may be a little bit of joint swelling, but at the same time, as soon as that foal is standing, the disease process doesn't happen quite that quickly because the bacteria has to get in there some way. And ultimately, some of these foals are coming out meconium stained, and they could have had access to bacteria earlier, but I think we're not seeing this immediately after birth. Usually we're at least about a week old when we're going to start seeing these. Yeah.
All right, I'm going to try to keep us on schedule. I know most of you here. I'm Laura Jevsikis. I'm the internal medicine specialist at Rhinebeck Equine. I've just celebrated my 10-year anniversary at Rhinebeck Equine. Time flies when you're having fun, as they say. Oh wow, didn't need applause, but anyway, still excited for foaling season. So as everyone knows, I love babies, especially the sick ones. So today we're going to talk about foal colic and diarrhea. There's a lot of information to cover in a relatively short period of time. I probably have too many slides, but you probably all know that I also talk pretty fast. So we'll get started. So I tried to break this down to think about age predisposition for some different diseases because it really does change pretty distinctly as our foals age. In the newborn, less than 2-day-old range, we can see enteritis, ileus, or enterocolitis, which we'll see across the board here, gastric ulcers, and then we have meconium impactions and strangulated inguinal hernias. When we're just a little bit older, so at that sort of 2 to 7 day mark, we can add uroabdomen from a ruptured bladder onto the list, as well as some of our congenital abnormalities, Atresia coli and ani. And then as they get older, we have more variety. So we add gastroduodenal ulcer disease to our run-of-the-mill just gastric ulcers, as well as Lawsonia intracellularis, ascarid impactions, small intestinal volvulus, intussusceptions, and strangulated hernias. So we're going to go through all of these problems. But first, I just wanted to very briefly talk about the wonders of the equine GI tract, probably the most poorly designed system. This is representing the adult GI tract. And so in adult horses, and this is sort of a precursor to help us understand why we see some of the disease we see in our foals, and why it changes so much as they age. Because in the adult horse, our enzymatic, is this working? There we go. Our enzymatic digestion happens primarily here in the small intestine, and that's where the protein and virtually all the carbohydrate is digested. And then in the hind gut, the cecum and colon, there are massive quantities of bacteria and microbial digestion occurs, and that's what breaks down fiber. And that's really important to the digestion in our adult horses. So in our foals, that large intestine really isn't functioning that way just yet. Foals have an underdeveloped cecum and colon,
And so most of the digestion is happening in the small intestine. And so that's why their dietary needs are so different, much more low fiber, things that can be easily digested in the foregut, such as milk. And so as our foals age, what they're really doing is populating their large intestine with bacteria and fungus that helps them digest fiber going forward. The equine microbiome is an area of a lot of research right now, the GI microbiome in particular. Do not ask me to explain how any of this was done, but we're just going to look at the pretty colors because the point I want to make is basically what I can tell you about this graph is that the closer the dots are to each other, the more similar in population those organisms are. So they basically take fecal samples from horses as they age and look at the diversity of the organisms in their colon. And what's really interesting is these are 1-day-old foals down here, 7-day-old foals. The blue is 28-day-old foals, orange 60, purple is a little hard to see. They're kind of mixed in here. That's weaning, and these are the mares on the day the foal was born. So as they age, their microbiome also ages and gets closer and closer to an adult horse. We know this is of tremendous importance, both to keep our mares healthy, to keep our foals healthy, probably to prevent some of these infectious kinds of diarrhea that I'm going to talk about later. What we really are very bad at right now is manipulating it in appropriate ways. So I'll mention probiotics, prebiotics later, but right now we know it's really important that they have a good balance. We're just not great at figuring out how to manipulate it in a positive way. We're really good at screwing it up. But just keep this in mind as those foals age, it's really their colon that's learning how to digest fiber in their diet. It's also pretty fascinating because when they did this study, they could actually see there's different slight variations from farm to farm based on what those horses are eating. So also important to think about that we want to keep our mares' diet and microbiome as healthy as we can because that's going to be the source for those foals. Okay. So I'm first going to talk about colic, and then we're going to switch gears and talk about diarrhea, colitis in the second half. So some basic causes of colic. Some of you have probably seen this before, but I think it's really important to keep in mind because a lot of times someone will call and tell us that their foal is straining, and it is a good thing to be able to differentiate if they're trying to urinate or defecate. So when they're trying to defecate, such as with a meconium impaction, they tend to have their back arched like this versus posturing to urinate like this. So just a good reminder. Meconium impactions, really, really common cause of colic in those very young foals. As was mentioned at the beginning of the day, really important to take note of whether or not the foal has passed meconium and when they did that. These foals typically present straining to defecate. Colicky, they may have abdominal distension depending on how long it's been going on. In terms of diagnosis, we often do a digital rectal exam, see if we can feel a lot of meconium sitting in the rectum, and then ultrasound and radiographs are ultimately extremely helpful. So this is a radiograph of a foal with a meconium impaction. We can see some gas distension in the intestine here. This big gas cap is in the stomach. And then we can actually see the meconium within the pelvic canal. Ultrasound, what we see is this speckly, what we call heteroechoic appearance. I have another a video for you next, with this very sort of varied hyperechoic material. And often we have to look way up in the inguinal region with our ultrasound probe. Sometimes we will put the foal on the ground on their side to get a better look. And then we can also see this massive colonic distension. So as things progress and all the gas starts to back up, their intestine gets more and more distended and their abdomen gets more and more distended externally. This is a video of a meconium impaction. So this is the small colon with the meconium in it. You can see how it has a sort of variable appearance to it. Treatment for these foals, I do typically put these foals on antibiotics. They're very susceptible to becoming septic, and anything that's going to inflame the intestine is going to make them more susceptible to a systemic infection. Nutrition, these fools are dependent on milk for glucose, on calories at that time. And so if they're colicky and things are backing up in their intestine, then sometimes we do need to keep them off the mare and prevent them from nursing for a short period of time. And in those cases, it is best if they're in a hospital situation so that we can provide them fluids with glucose while they're being held off the mare. That's also going to keep them hydrated at the same time. And then with all sick foals, we're always thinking about, do they have adequate passive transfer immunity? Is their IgG adequate? So all the routine nursing care things apply in these situations. I will give these foals Banamine. I always feel better if I can check their hydration and their kidney function. But your average, otherwise systemically healthy foal is going to tolerate 1 dose of Banamine quite well. I will typically pass a nasogastric tube to see if they have fluid backing up into their stomach. If they do not, then I will administer very small amounts of mineral oil and milk magnesia to help break up that impaction from the front end. And then enemas were mentioned this morning. I completely agree with Dr. Goslin. My rule of thumb is no more than 2 fleet enemas per foal. That's because the fleet enemas contain very large quantities of magnesium and phosphorus, and you can actually really mess up their electrolytes if you overdo it with a fleet enema. Soapy water enemas are very safe and can be a good sort of second step after fleet enema. But in a situation where we really have a colicky foal with confirmed meconium impaction with our imaging, I am a huge fan of retention enemas, which we do with a compound called acetylcysteine, which actually helps break down the meconium. So if you take meconium and put it in acetylcysteine, it will dissolve it. And that's important to remember too, because when it resolves, you're not going to see meconium come out. You're going to see just paste. That means it's doing its job. So to do this, I typically sedate them. I will actually give them a very, very small dose of Buscopan, which helps prevent them from straining against the catheter that we'll use. And I often give them a bolus of fluids while they're sedated and down, because that's an easy time to give a full bolus. So this picture is a little confusing from the angle, but this is what we do is we raise the foal's butt up in the air, and we pass a Foley catheter into the level of the hip here and clamp off the catheter so the fluid is retained within the rectum and small colon. And I try to keep them down with the catheter in for at least 15 to 20 minutes, depending on how feisty they are. And as I said, often this is we'll do fluids at the same time here. Reasons or times when I would become worried after treating a meconium impaction or during treatment is if they do start to have reflux, just a sign that things are really backing up and nothing's going through their system, and really need to think about fluids and calories in that case. Progressive abdominal distension. When we have hospital foals, we routinely measure their abdomen, just measuring tape. We clip little marks on them, and it's a great way to slightly more objectively tell if their abdomen is starting to become distended. If they're not responding to pain medication, and then if they have free fluid in their abdomen that starts to look like it has little flecks in it or is hyperechoic, then we worry that they're starting to develop peritonitis, which can happen if that intestine becomes severely damaged and starts leaking. So this is what we want to avoid. This is the radiograph just showing gas everywhere, free in the abdomen, in fact. And then on ultrasound, this is the lung, the diaphragm is here. And then we could actually see a free gas shadow in the abdomen. So that is not, we want to get ahead of the game before we get to that point. I just wanted to mention, these are fortunately incredibly rare, but there's 2 congenital abnormalities that can trick you, because initially it may seem like a meconium impaction because they're straining to defecate. However, key thing is that in this case, there is no meconium, because what this means, the atresia means that there's the lack of an opening. And so this is a barium study. So the barium is put in through the rectum. This is atresia coli, which means that there's this blind-ended pouch to the colon. It's not connected. And in the case of atresia ani, just like it sounds, there's no opening to the rectum. These are not good problems. Unfortunately, they are really, really, really uncommon. But again, just to sort of a red flag, if they look like they have a meconium impaction, but you're not seeing any meconium at all, just keep it in mind. So uroperitoneum, or a ruptured bladder, this just means urine in the peritoneal cavity. This ultrasound picture on the left is actually incredibly rare to have. So we could actually see this very, very thin. This is the bladder right here. We can see this very, very thin spot on the wall. And this is all free urine within the abdomen. This is a full with a very obvious round distended abdomen. When they have abdominal distension like this, it can be fluid. The fluid can be urine. It can be blood. This can also be gas distension, secondary to meconium impaction. So ultrasound is really our friend in these cases for helping to differentiate. These foals typically are straining to urinate, might be dribbling urine, and this is most common in that 2 to 7 day range. So usually doesn't become if it is a ruptured bladder, it usually ruptures at birth, more common in colts, but it often takes a few days for them to actually start showing any signs from it. So you may not see it right away. These foals often are not nursing well, have high heart rate, high respiratory rate, and it's not uncommon that they may have signs of systemic sepsis as well. One of the problems we have when we try to treat these foals is that they can develop severe electrolyte abnormalities. So their sodium and chloride go down, their potassium goes up. When their potassium gets really high, it can slow their heart rate down, and they become an anesthetic risk. And their azotemia is from their kidney values going way up because their urine is going into their peritoneum, and then what happens is it actually goes back into their bloodstream. Okay, this is just another video showing this is the bladder here, but then we can see all this free fluid here. And in this case, you might be saying, well, why does the bladder still look distended? Well, what we actually see, what I see more often than a true bladder rupture, is that the urachus, the area just inside the umbilicus, often starts leaking. And that is usually secondary to an infection of that structure. So they get an umbilical infection that is internal as well as external. And that tissue becomes so inflamed that they start leaking urine from that structure into their abdomen. And in those cases, the bladder can appear intact. The bladder still fills. It just is a slow leak out of the urachus. That's the bladder rupture. So in addition to the ultrasound and seeing that free fluid, the more definitive way that we diagnose these foals is that we take a sample of that fluid from their abdomen and we measure the creatinine, which is that kidney value that I mentioned, and we compare it to the blood. So if the fluid in the fluid in the abdomen has a creatinine that is double what it is in the blood, that confirms that it is in fact urine. When we take that sample, I will often do a culture because that fluid can be septic, particularly if it's that situation where it started with an umbilical infection and then started leaking. So treatment, this is a true surgical emergency. I'm not going to fix this. I need my surgeon friends. However, because of those electrolyte abnormalities, it often takes us a little while to get them stable enough and get those electrolytes fixed so that they can safely be anesthetized. In the meantime, they are getting broad spectrum antibiotics. I do a blood culture on them to check for sepsis, as we do with every sick foal. And then using some special fluid combinations to try to get them stable enough where they can be anesthetized. The prognosis is quite good if it's an uncomplicated bladder defect and even the umbilical infection. What happens is that entire umbilicus is just resected surgically and repaired. If they have other diseases, if they're septic, have failure passive transfer, other things going on, then that can decrease prognosis. Okay, strangulating inguinal hernia. So this is actually a gypsy Vanner foal that we had in, I believe this was last year, that came in at about 16 hours of age. So this can happen pretty early on. And so they can have an inguinal hernia, and they can have, meaning a hole in their in the ring where their testicle is descended. But if the small intestine isn't stuck in that hole, it may not cause a problem. So you can have an inguinal hernia without colic and without it being strangulated, but once that intestine gets into the hole and gets distended, it can get stuck there. And so it's an important differentiation because it makes a difference in terms of when and if we're going to fix the problem. So in this case, you can see this very large distended scrotum here. I think Dr. James may have actually sent this case to me. And then on ultrasound, so this is taking the ultrasound probe right over this area of swelling, and these are all loops of distended small intestine in that scrotum there. And in this case, we were not able to reduce it, meaning we were not, even with the full anesthetized, we were not able to get the small intestine back through that hole. So this did become a surgical emergency. This is the cute little gypsy banner under general anesthesia being monitored here. And in this case, they were able to go in through the scrotum, reduce the hernia, and they did do a unilateral castration. So it's always a conversation with the owner because that testicle is going to be, has to go so that they can close the hole down and nothing goes back through the hole again. In some cases, they may go ahead and do a bilateral castration at the time. It depends on what the owner's desired future is for the animal. Okay. Gastric ulcer. So these can happen at any age, from birth to death. But in neonatal foals, they're actually quite different than in other age groups. So it's been reported that the prevalence in foals is 25 to 57%. There are no studies on prevalence specific to critically ill neonatal foals. But what we do know is that the anatomic location and the cause of ulcers changes dramatically. So in our neonatal population, the sick foals that I see, they primarily get ulcers in what we call the glandular region of the stomach, because they have decreased blood flow and decreased perfusion to the stomach. It has absolutely nothing to do with acid. Whereas our older foals and our adult horses, when they have disease in the squamous portion of their stomach, that is caused by acid, the presence of acid in the stomach. So it's a totally different thing, and therefore our treatment needs to be different. And our primary treatment is supporting that foal, making sure their blood pressure is adequate, they're well hydrated, treating all their systemic disease so that their stomach is well perfused. Clinical signs can be, they are more likely to have diarrhea with ulcers than an adult horse, and that's because their GI tract is working completely differently, as we talked about at the beginning. They can act colicky. This is sort of the classic lying on their back position. It's thought that this might kind of relieve the pressure on their stomach and shift around all the fluid in their stomach. Bruxism is grinding their teeth and excessive salivation. So while the supportive care is the most important part, we will often also treat these foals with some antacids. I don't scope these foals as I scope adult horses practically every day. But these little guys, I'm not going to scope them unless I really, really need to, because it's a big scope. I don't want to sedate them if I don't have to. So that's part of the reason we don't know the prevalence as well, because it's not something we're just going to do for the heck of it. We do have some of these foals that have severe GI disease, might be refluxing. We can't give them oral medications. There is an IV proton pump inhibitor called pantoprazole that we can use in foals. Of course, quite expensive, but in some situations that can be helpful. So as these foals get older and we get to this weanling stage, we have this fun new syndrome that we call GDUD, or gastroduodenal ulcer disease. And this is quite different from the stomach ulcers that we see in adults or in neonates. So this is actually ulceration in the proximal duodenum, right where it leaves the stomach. And they often also have squamous and glandular lesions in their stomach, and their stomach is typically quite distended. Why this happens at this age, we still don't really know, but it is more common in foals that were sick, specifically that had diarrhea, and specifically rotavirus diarrhea as babies. And they tend to be the ones that present with this as in the weanling age stage. So these foals typically are kind of poor doing foals, poor hair coat, ill thrifty, and then they can present because they're grinding their teeth excessively. They may have colic, they might be salivating excessively, and they may have some diarrhea. Their stomach does not empty normally, but it happens because of this inflammation in the proximal duodenum, and so they can end up with a stricture there, partial or complete, that doesn't allow food to go through their stomach. What happens is in adult horses with small intestinal colic, their stomach gets very distended. They are acutely, violently colicky. These foals are not that way because their stomach is distended very, very gradually over time. So they're much more tolerant of this gastric distension than in another scenario. So they can be a little bit sneaky. But when we scope them, we typically see horrific ulcers. And then the real definitive diagnosis is to do a barium study where we give them barium and we take radiographs and can see how long it takes it to exit the stomach. So this is a postmortem photo, which unfortunately is how many of them end up. And this right here, so the stomach is over here on the left. This is the duodenum over here. And this is showing the strictured area right here. So what can happen with these foals if they're not treated aggressively is that can become a complete stricture and their stomach can get so distended that it may rupture. They also very often have secondary liver disease because the bile duct empties into the duodenum right about here. And so when things aren't moving through, then the bacteria goes up into the liver. So there's two different ways we can approach these foals. We can try to treat them medically with antacids, prokinetics, keeping their stomach empty, so keeping them with a stomach tube in, fluids. They definitely need antibiotics and also IV nutrition, which is quite expensive because they're not going to be able to get the calories they need orally. With medical treatment, what's reported is about a 50% survival to discharge. And this is really only even an option if that stricture is just a partial stricture. There is surgical treatment, either a gastroduodenostomy or a gastrojejunostomy, which essentially involves rerouting the exit of the stomach to a different part of healthy small intestine. It is not a great surgery. They can have obstructions, they can have adhesions, they can have post-op ileus. What's reported in the papers is 50 to 70% long-term survival, but most of us feel that that's pretty optimistic. So it is certainly an option, and it would be my choice over medical treatment, but it's not a nice disease in any way, shape, or form. Small intestinal volvulus. So this tends to happen in the 2 to 4 month old foals. And this diagram here is just showing, so this is the mesentery. It's this sheet of tissue that attaches all the small intestine to the dorsal body wall. So just sort of below the spine here. And what happens is this intestine rotates on the mesentery. So it's literally like you just take the mesentery, you spin the intestine all around. The problem is that the blood supply is also in this mesentery. So as soon as that small intestine, the mesentery is twisted, then the blood supply is cut off to that intestine. These foals tend to be severely colicky. They often get distended fairly quickly. And they may or may not actually have a lot of fluid back up into their stomach because so much of the small intestine is involved that there's not much to actually back up into the stomach because of where the twist is. This is just a picture showing the same thing sort of from above looking down at the twisted mass of intestine. So again, ultrasound is really, really helpful in these cases. And what we see are these distended loops of small intestine that are not moving, an increased amount of free fluid. These walls are also starting to get thick. So the longer the blood supply is cut off to that intestine, the thicker the walls get, the more damage the tissue gets, the worse our prognosis is. So this is a really important one to be aware of because this is a good reason not to wait on a colicky foal in that age range. Because if they have a surgical option and we can get them to surgery quickly, they can do well. But the longer that small intestine stays with no blood supply, the worse our prognosis is. This is a picture of a neutrophil, a white blood cell with bacteria inside it, to remind me to talk about the fact that sometimes when this intestine starts to get compromised, we also get secondary peritonitis or an infection in the peritoneum because of that damaged tissue. So this is just an intra-op picture. And so this shows that twisted mesentery perfectly. I mean, it's literally basically in a knot. And so what we do is try to untwist it, not we, my surgeon friends, untwist it. And then sit and watch it to see if the color comes back, if the motility comes back, and try to make an assessment of what the full prognosis is. Sometimes the answer is very clear and the intestine is very black after it's been going on for a long time. So there's shavings right here. So that should be it. This foal did not, unfortunately, even have a surgical option, but we did a postmortem exam and found that. So it was pretty dramatic. Okay, ascarid impactions. So this is typically in our older foals, so starting to get into the weanling age. I could do an entire separate talk on worms, but this is what we want to avoid, right? So this is small intestine. This is one of my favorite videos of all time. Oops, you can't see it. Okay, so this is a thickened loop of small intestine, increased free fluid here. And these little bright guys, those are the ascarids saying, hi, I'm here, I'm stuck. So we tend to see this in weanling age foals that have a high ascarid worm burden. Classically, this happens after they're dewormed and those worms start to die. They get this big mass of dead ascarids in their small intestine. It can cause an obstruction, and so they start to colic because of the obstruction. So we try to treat these foals medically by keeping their stomach empty. They often have fluid backing up into their stomach, rehydrating them, antibiotics, anti-inflammatories, pain medication. I try really, really hard to treat these medically because that intestine is incredibly inflamed and really doesn't like to be handled. And there's a pretty high risk of adhesions or scar tissue forming if they do need to go to surgery. However, sometimes if they are in unrelenting pain or we are suspicious of a volvulus forming or an intussusception, which I'll get to in a second, which are both things that can happen when the motility of the intestine is disrupted, then sometimes we have no choice but to take them to surgery. This is just a great picture of, this was actually I believe this was a 7-month-old foal that I saw in the field for colic. And when we looked in the bucket of reflux, there are all these nice ascarids. That's why you should not put your mouth on the stomach too. So this is what we call a jejunal intussusception. So what an intussusception means is that the intestine, it doesn't have to be small, the intestine telescopes one piece inside of the other. And so this is a slightly more normal small piece of small intestine. This is a thickened loop. And then this has a loop within a loop. So we call this a target symbol. And I don't think that's a video. The next one's the video. There we go. So here's our double loop here, and this is the distended small intestine that's in front of that. So this essentially causes an obstruction. These typically also do need surgery. This happens because there's something wrong with the intestine to start with. So worms, diarrhea, some sort of inflammation that's making it sticky, and so it gets stuck inside itself as it's trying to contract and telescopes in like this. So prognosis with abdominal surgery. Now I want to point out the year here. This is an old paper. There's actually no more recent data. We have gotten a lot better, but just to say that we really try hard to avoid abdominal surgery in these foals because there are more anesthetic risks, as with any species. And their intestine does seem to, they do like to make adhesions a lot. But when there are those certain situations where if we can catch them early, their prognosis can be quite good and they can go on to normal athletic performance. Okay, we're gonna switch gears and yep, I've got 10 minutes. Cool. Talk about all the causes of diarrhea. So just looking at age predisposition. So I broke these out a little bit further. And some of these will go across the board. So Clostridium perfringens, Clostridium difficile, we can see at any age. In our neonates and our older weanling age foals, we see rotavirus. So rotavirus tends to have 2 spikes, salmonella across the board. Rhodococcus, we start to see in that 1 to 4 month age group. I'll talk about Enterococcus durans, and septicemia alone can also cause some diarrhea. And then weanlings, we get into Lawsonia, which I'll talk about. Okay, so enteritis in general just means inflammation. So specifically enteritis is more of the small intestine. This is classic thick loops of small intestine not moving well, but they're not those big round distended loops like we saw with the volvulus. These foals often have decreased nursing activity. They may have diarrhea, fever, low white blood cell count. Now I'm going fast. So this is another ultrasound. Sometimes we'll actually see some gas. This bright white is gas in the wall of the intestine. That always makes me suspicious of Clostridium. With colitis, we tend to see fluid in the colon. So all this is diarrhea waiting to happen. General treatment for enterocolitis. So the entero is small, colitis is the large intestine. Broad spectrum antibiotics. We want to prevent sepsis. Again, the inflamed intestine, bacteria goes across the wall and can make these full septic. Gastroprotectants, anti-diarrheal agents, Pepto-Bismol, Biosponge. There's nothing new. Very small amounts of Banamine. We just have to be judicious and watch their kidney values. Fluids, huge fan of plasma. Probiotics, as I mentioned, really someday we'll be there maybe, but right now we really don't know how to manipulate that bacterial balance, but it makes us feel better when we give it to them. And nutritional support, these foals are really dependent on milk. So I'm just going to go through a few of these specific causes. Clostridium perfringens happen very early in the 24 to 5-day-old group. These foals are typically not nursing, have fevers. Classically, they have yellow, very distinctly malodorous diarrhea, and this can progress to hemorrhagic diarrhea. So when I see this, I'm most suspicious of Clostridium perfringens until proven otherwise. And one of the big issues with foals with this pathogen is that they can get dramatic gas distension and colic also. And so this can masquerade as primary colic, and so we have to really use our ultrasound, our blood work, other things to make us convinced that it's more of an infectious problem than another cause of colic. And they can actually get so bloated before they even pass any diarrhea. And that's, in some ways, that's kind of the problem. It's like everything just shuts down and they get this massive distension before having diarrhea. This is highly contagious. Diagnosis primarily these days is through PCR. It is really important to identify which toxins are involved. There's a bunch of different toxins, and that can make me more or less convinced about whether or not that Clostridium is truly causing our problem or if we have something else going on, but that's a bit academic. Antibiotics, so specifically to target Clostridium, metronidazole and penicillin or ampicillin are our friends, and then supportive care to try to get them through this. C. diff can happen with any age. This one's a little bit different because it's 10% of healthy horses shed C. diff after hospitalization or antibiotics. When we have antibiotic-induced colitis, which is more common in older horses once they've established those microbiomes in their colon that I was talking about, then we mess them up with antibiotics. So often antibiotic-induced colitis is the result of a C. diff population exploding in their colon. These foals are typically not quite as sick as those with C. perf, and it's not quite as contagious, but still is contagious. Again, diagnosis is with PCR, treatment is the same, but we don't see that hemorrhagic diarrhea and the amount of abdominal distension like we do with C. perf. So salmonella, Dr. Taima mentioned this already. This is not, and not that we want any of these, but Salmonella is highly contagious. It's also zoonotic, so you have to be really cognizant of you and your staff. Foals are most often affected in 12 hours to 4 months of age, but this can affect horses of any age. They often have fevers, depression, dehydration. This is typically brown-green diarrhea. Secondary issues are really common. So septicemia, joint ill, uveitis are all red flags that we might be dealing with salmonella. So testing is based on PCR. Culture is also really important with salmonella because that is what's going to tell us which antibiotics it's susceptible to. So PCR is really, really sensitive. Sometimes it's too sensitive because it can pick up very small amounts of the DNA of the salmonella. And the salmonella may be there and not actually be causing the problem. Whereas if they are culture positive, then we know that we have an issue. And that can help us guide treatment. So treatment should be based on culture and sensitivity, but typically we're reaching for our aminoglycosides like amikacin. In this case, it's a gram-negative organism. So Enterococcus durians, I just wanted to mention briefly because this is kind of a new emerging disease to be aware of. And it's a bacterial infection that has been associated with farm outbreaks, typically seen in 2 to 10-day-old foals. And it can be isolated from blood, joints, and umbilical infections. Fortunately, these foals are not terribly sick, and it may be a co-infection in some cases. Testing is with culture and PCR. However, there's only very select labs right now that are looking for this or testing for it all. There's only one lab that has a PCR that I'm aware of. So where we're sending our samples makes a really big difference. And when I'm speaking to veterinarians, I always really harp on that because you really have to make sure you know what you're testing for and what your lab may not be looking for. So I would start to think about this if I had multiple cases of diarrhea on a farm and we weren't getting an answer with our routine diagnostics. Fortunately, they tend to not be as sick as the C. perf and salmonella foals, but it can cause significant morbidity. This organism is susceptible to penicillin and ampicillin. Okay, I'm going to spend a little bit more time on rotavirus because there's some new things to talk about. So rotavirus in general is this nice, pretty little virus here. And one of the big reasons it is such a problem is that it's what we call a non-enveloped virus. So some viruses have an envelope around them, and that makes them easier to kill with disinfectants. If there's no envelope, they tend to be hardier viruses that are harder to kill. And what rotavirus does is it attacks these cells. This is the what we call the villi in the small intestine. And the cells on the tip of the villi contain all those enzymes that I mentioned at the beginning that digest carbohydrates for these animals. And the rotavirus attacks those cells selectively and destroys them. And so these foals have severe malabsorptive diarrhea, and then that whole carbohydrate load is going on to their colon, and they have what we call secretory diarrhea as well. So that is why this infection can be so severe, because it destroys all those enzymes they use to digest their food. So we now have 2 types of rotavirus. One wasn't enough. So rotavirus A is what we've all kind of known for a very long time. Very common, highly contagious cause of diarrhea in foals. And again, this has those 2 peaks, less than 1 month and then 4 to 6 months of age. The neonates often require more supportive care. Decreased nursing, rapid dehydration is common. And then older foals may require minimal intervention. They might still just be eating and bright and really require not much. They just have diarrhea. This diarrhea is typically gray or pale, another distinct odor. I wish I had like scratch and sniff rotavirus, just kidding. So treatment, supportive care, there's no specific treatment for the viral infection. It's all supportive care, fluids. The neonates, I definitely still put on broad spectrum antibiotics because of that risk of translocation of other bacteria through their intestine. But the one I really wanted to mention is rotavirus B. This is the novel strain that was identified in central Kentucky in 2021, just when we needed another infectious disease to worry about. This is not contained in the vaccine that we vaccinate mares with. And unfortunately, there really doesn't seem to be much cross protection between the vaccine for rotavirus A against rotavirus B. This clinically is very similar to A. Severe diarrhea, 1 to 4 day old foals. They were seeing morbidity up to 100% on farm. So that means that all the foals on the farm were infected, all had diarrhea. Kind of a nightmare. Again, only a few labs are testing for this. So now there's 3 that I'm aware of. Maybe there will be more this year, but you still have to make sure that they're actually looking for what you're worried about. So rotavirus has really unique biosecurity challenges. Because of that lack of an envelope, as I mentioned, it's resistant to many disinfectants. There's also a huge number of particles shed. So there's 100 billion particles of rotavirus per gram of feces, which is pretty astounding. And they can shed for up to 3 days after the diarrhea resolves. So just because they don't have diarrhea doesn't mean you're out of the woods. It's also highly contagious, meaning that you only need a very small number of particles to infect another foal. And the particles survive in the environment for up to 9 months. So contaminated bedding and manure are a risk, and it's a reason to avoid spreading manure. Overcrowding is also a risk, as with any infectious disease. Just to mention, so knock on everything. As far as I'm aware, we haven't had a lot of cases of this yet in New York. Maybe this will be our year. But I did, sorry, you can throw things at me. But I did diagnose this in a foal last year. I was actually an older foal who also had C. perf. So the foal did fine, probably because it was older. But I think we all need to be very much on the lookout for this. Lawsonia. So this is another disease that is endemic in many farms in Kentucky, more sporadic here, but again, really important to be aware of. This affects 4 to 12-month-old foals. This disease was first identified in pigs. It also happens in weanling age pigs. Not quite sure. It probably has to do with that shift in the way the GI tract works, but no one quite knows why is this age group specifically. But we see it in the fall and winter because of when our foals are that age. This causes what we call proliferative enteropathy, which means that we get thickening of the small intestine and they lose a lot of protein through their GI tract. Clinical signs are pretty variable. They can be depressed, they can have colic, diarrhea, weight loss, anorexia. They might have a fever, they might not. And edema is a really classic sign. And usually what we'll see first is just mild throat latch edema. So it's a good thing to look at when you're checking your foals daily and taking their temperature daily. Just maybe run your hand under their jaw because that's where you'll notice it first. Their white blood cell count can be high, low, or normal. But with a classic thing that we see on blood work is that their protein is really low because of all that protein loss. They also may be ill thrifty, poor hair coat, pot-bellied, etc. And so what we see is this on ultrasound is this sort of pathognomonic thickening of the small intestine. This is 1 centimeter thick. It should be 3 millimeters, 0.3 centimeters thick. So really dramatic thickening. They're not all that dramatic. This is one I had this fall. But you can see, so there's a distinct loop here with a thick wall. Here's another thick wall here. Here's a loop with a thick wall. This was 0.35 to 0.5 centimeters. So diagnosis, PCR on the feces. There's also a blood test for it. And they may be positive on one or the other, depending on what stage of the disease they're in. For treatment, you typically start with the oral tetracycline, so doxycycline or minocycline. The macrolides that we use for rotacoccus can also be effective. And I should actually have chloramphenicol on this list that we'll use in some cases as well. These foals often need a lot of plasma. It's not uncommon for them to come in with a protein of around 2, so half of what it should be. And nutrition is really key because they are not able to digest their food and absorb their food because of all that inflammation in their intestine. So I really want to harp on prevention, and I really think it's worth thinking about. That foal I showed you an ultrasound of from a few slides ago from this fall was the only case on the farm. They have about 30 foals per year. And most things for most of us are going to be a, cost benefit analysis. That one foal had a hospital bill over $10,000 and it's still not doing well. So it's, even if it's one foal, it can be a huge, huge cost to try to save them. And we also now see cases that have, they get necrotizing enteritis with this and get really, really sick and are very, very hard to save. So sometimes it can be a very mild sort of self-limiting disease, but sometimes they can get very, very sick from it. And for many years now, there has been, so this is a pig vaccine. It's a modified live vaccine that we administer intrarectally. And the initial studies what's been recommended is 2 doses, 1 month apart, starting in July. So basically a dose in July, dose in August, in preparation for the time of year when they're typically affected. There hopefully is going to be a paper coming out soon, but anecdotally, there is a study that was done in Europe suggesting that 1 dose may be just as effective, which would be really nice. It's about $75 to $100 per dose. So it's not the cheapest vaccine out there. But again, if you've got your one valuable foal, it's not a great disease to have. So it'd be better if we can get ahead of it. Oh, I'm already over. Okay. This slide is just to remind me to say, I get a lot of questions. I just had the conversation this morning with someone about why should I pay for a diarrhea panel? Because when we do PCR diarrhea panels, it's actually, you get a lot of bang for your buck because you test for all these diseases, everything that can cause an infection, GI infection in a foal all at once, but they're expensive, like in the $300 to $400 range. But from a farm standpoint, it is really, really valuable to know what you're dealing with and how concerned you need to be, how rigorous with biosecurity you really need to be. Because if it's rotavirus, like we need to burn down the barn. Exactly. We need to be on it, to try to prevent it from getting out of hand, especially if you have a lot of foals. Obviously, if in a situation where there's only a few foals on the farm, it may be different. But I really think it's worth spending the money so we know what you're dealing with. Certainly for the individual foal, a lot of times they're better or not by the time we have results, but at least I know what to recommend for them going forward for the rest of the farm. And sometimes it does also dictate how long we treat them with antibiotics. For example, with the clostridial diseases, I'll often keep them on metronidazole for 2 weeks once we have a diagnosis. So biosecurity could also easily be another whole talk. Just a few really key points. Cleaning and disinfection is key. Organic material is not your friend. So another tidbit, adult horses produce 50 pounds of organic material per day. That's a lot. Reducing organic material reduces your pathogen load by up to 90%. So it can make a huge difference. Think about what your barns are made of. Dirt and wood is not easy to clean. Overcrowding, also not your friend for any infectious disease. I do not expect you to be able to read this. Just to point out, we have a lot of disinfection agents. They're all very different. We have some new things available, and I am a huge fan. This category here, the peroxygen compounds, we use Rescue extensively in the hospital. It's hydrogen peroxide based. It's much nicer for your barn, your shoes, your foot mats. It works well in the face of organic debris. These little checks down here, so it's bactericidal, virucidal, fungicidal, kills tuberculosis. We don't really care about that, but sporicidal. So that means it also kills Clostridium spores. If you're using bleach, just stop, please. It's not doing anything. Bleach is great in a metal container with no poop in it, but it's not going to work when there's organic debris there. So, and these are really, they're much better for the environment. It's much less harsh. So I'm a huge fan, not paid anything by those companies, just FYI. So just a few things to think about, things to minimize: foot traffic in the barn, visitors in the foaling barn. I know everyone wants to come see their cute babies, but think about what they're spreading around. Leaf blowers, you can be blowing all of those pathogens all around. and pressure washing the barn when it's occupied. So you may just be aerosolizing infectious particles. Things to consider: using personal protective equipment, gloves, foot baths, dedicated staff, dedicated tools, meaning pitchforks, shovels, etc. Vacuum machines can be great for cleaning without aerosolizing all the debris. It's my last slide. When to refer right away. Yeah. So colic, I think if they have severe signs of pain, they're bloated, fever, diarrhea, refer. Diarrhea, it's really dependent on people's availability to treat on the farm. Some of you out here have great staff, can certainly handle running fluids occasionally, but there's a lot of things we can monitor in the hospital setting that can play a huge difference. Their electrolytes, their acid-base status, all these things. If they're less than 1 week of age, they're going to be much more susceptible to septicemia. And then I also put in if they're dull and not nursing after a few days and they've had fluids and antidiarrheal meds. So in other words, they go from bright nursing and then all of a sudden they're like really, really dull, don't want to nurse, down in the dumps. Often what's happened in this case is that they're really acidemic because they've depleted their bicarb stores, which is something we cannot tell without running a blood gas, which is a blood sample that has to be run right away. So just a red flag to me. I always say, okay, can you bring the full in, or can you bring me blood that I can run in 30 minutes? And then if they have diarrhea and colic, I definitely don't like that combination. That's it. That's my email. It took me 10 years to figure out that I could have an alias that's just Laura at Rhinebeck Equine, so you don't have to spell my last name. You're welcome. Does anyone have any questions? Yes.
Run your hands under the jaw.
Oh,
I didn't understand.
sure.
What that was
Yeah, so the question was about with Blessonia, running your hand under the jaw. So they often, if they have edema, fluid in their soft tissue, it often starts in the throat latch region. So and a lot of times, especially if they've got a lot of hair there, you can't see it. So if you just run your hand under their jaw, right at the throat latch of the halter, you may feel edema there. It may be squishy, it feels swollen and squishy. That's a great question. So the question was from a full building their healthy microbiome standpoint, if it's better for them to be born later in the year, so they're outside more instead of being in a stall. I'm not aware that anyone's looked at that yet. They have looked at the mare's diet, and it definitely does influence the foal, which makes sense, right? Because I mean, they're literally, it's normal for them. Coprophagy is when they eat the foal's manure is completely normal. That's how they're populating their intestines. So that's why thinking about having your mares on a good diet is really important. But I don't think we know. Right. I would, so from a hay versus grass standpoint, that may prove to be important, but what we know makes a huge difference is more grain versus is bad. But hay, forage should be the staple of all of our horses' diet, whether it's hay or grass. High amounts of grain, specifically carbohydrates, it definitely shifts the adult horse microbiome and changes that bacterial balance. Yeah. Sure. So the question was about heart murmurs in newborn foals and when people should be concerned. So one of my great mentors always told us that if a foal doesn't have a murmur, then it's not alive. And that is because it is normal for foals to have a low murmur at birth. If they have a heart murmur beyond 7 days of age, that is when I start to get concerned. And depending on the type of the murmur that your veterinarian hears, an echocardiogram may be indicated. There's some normal structures in the heart that close down after birth, and sometimes those are a little bit delayed in closing. But beyond that 7 days, we really shouldn't hear a significant heart murmur. And we do see congenital heart defects in foals. I usually have 1 to 2 per year. Some breeds it's more common in some breeds, Arabian specifically, which we don't have a lot of in this area, but also our thoroughbreds and standardbreds, it can happen as well. Okay. Should I repeat the question still?
Yeah.
Okay. All right. So the question was about rotavirus A, and if the foal has it at a young age, if it's possible for them to present again. That's a great question. And I'm not aware of any literature, but I'm also not aware of a foal that has had it again. So I would think that their natural immunity is going to carry them through that period. And so it's not something we usually see repeatedly, fortunately.
Another online question is there a product you recommend giving foals at birth to boost their immune system or digestive system?
Yeah.
Plasma.
Yeah. 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 Plasma is the best thing. Well, actually, yeah, second to colostrum. Colostrum provides local immunity in the GI tract. So that is the best immunity for the GI tract and the foal as well. But second to that is plasma. Otherwise, I'm not a huge fan of any of the alternatives.
So I know we talked about ulcers and like the foal. I had a mare, she foaled and then was back in foal for this season. Her foal was like 4 months old and presented with colic signs, and then we almost lost her. Like I was about to make that decision on her, and then my vet was like, let's treat her for ulcers, and she snapped out of it within a few days. Is there a way to like catch it before it gets worse, or like is there like a safe preventative when they're in like newly in foal, or
so yeah, I mean, gastric ulcers are extremely common in the entire horse population. I scope a lot of horses who don't fit the typical picture of a stressed horse. Old retired horses that live on pristine giant fields can have awful ulcers. So the best thing to do is have a scope done so you know where in the stomach the ulcers are, because we use different medications depending on the location of those ulcers, whether they're squamous or glandular ulcers. And I see a lot of brood mares actually that come in for colic, and we scope them and they have significant ulcers. In terms of prevention, so if we know that it's a horse that has had chronic ulcer history, some of those horses do need to be on a preventative dose of Gastrogard, which is 1 milligram per kilogram, which is 1/4 of a tube by weight, which is what UlcerGard is labeled for as well. But there's also some other alternatives that are they're not as powerful in terms of their anti-acid properties, but they may be helpful and are more affordable. There's Purina Outlast, which is an algae-based product that, so it's really without scoping them and seeing how they respond to treatment. Also, it's hard to know if it's a horse that just has ulcers one time and they're going to go away and never come back, or if they're going to be a recurrent ulcer horse. And there are some of those horses out there. Just as an aside, I didn't go into it because I had no time, but now that I have unlimited time, Gastrogard in foals is a bit confusing because and I don't like to use it blanket treatment across all sick foals, because we are blocking the production of acid, and the acid is actually very protective against a lot of these pathogens. And there was a paper done looking at the incidence of foals with diarrhea in a university setting in foals that came in for other problems, and they actually were more likely to develop diarrhea if they were on Gastrogard prophylactically than if they were not. So we just need to be careful with blocking the body's natural defense systems. Certainly the foals, like Dr. Time was mentioning, that are need to be on NSAIDs for long periods of time because they have painful orthopedic things going on. 100% I will put those foals on Gastrogard, but it's not something I'm going to reach for in every foal with diarrhea.
What about sucralfate instead?
Yeah, so the question was about sucralfate instead of GastroGuard. I love sucralfate. It is super safe. It's pretty benign, meaning it's not blocking acid. It is coating areas that are irritated, and it's really not doing much else. It's coating and promoting healing in those areas that are irritated. So I'm a huge fan of that. All my bed babies go on sucralfate instead of GastroGuard.
Just is bad for
Or in
sleep,
addition to, yeah.
right? It's bad for human sleep.
Yes. And some people, I work with a few farms that use ranitidine instead if they can get it. And there is some thought behind you're not blocking as much of the acid, so maybe it's better, but it's also pain to give because you have to give it 3 times a day, and who wants to do that? Yeah.
Just a quick comment on, I think you said something about grain and ulcers. About 4 or 5 years ago, we took our horses off all grain to mix their supplements with alfalfa pellets, and we had no more ulcer issues whatsoever.
Yeah, alfalfa is great for ulcers. It has higher calcium content, so. And there's many reasons we should steer away from unnecessary grain. I think certainly our brood mares are one population when they need more calories. We need to support them, but a lot of our horses out there, the easy keeping breeds, I recommend just forage based diets with a ration balancer and nothing else. So we still don't have great ways to prevent rhodococcus. Decreasing overcrowding can be very helpful. We see it most in farms with a lot of foals, drier conditions. We see more cases. Plasma, the studies are mixed on how well plasma helps prevent rhodococcus. There is some newer data supporting giving 2 liters of plasma, hyperimmune rhodococcus plasma is what I'm referring to, at birth, as opposed to 1 liter or 2 liter split at birth and 30 days, because we do know that they get infected very early in birth, and it's thought that perhaps just the higher number of antibodies in that larger quantity of plasma may be helpful. The problem with trying to study anything with prevention of rhodococcus is that it's so variable from year to year based on the environmental conditions of that year. And so it's really can be hard to determine if it's the preventative measures that are helping or just the changes, natural variation. But in general, I do recommend hyperimmune plasma for farms that have rhodococcus issues.
Can we talk about if there's any other management things that we recommend? Like, I know one thing that I would attribute to the spread of rhodococcus is using a leaf blower in the barn when there are mares and foals in the stalls. And so that's a common thing in like January and February when the weather's crappy, mares and foals are inside, and when they clean the barn, they just aerosolize all of that material up. Do you guys have any opinions on that?
Yeah, I mean, it's like air quality in general is really important, and it's contained in the dirt. And so when we blow the dirt around, we can spread a lot of things that way. I mean, actually using a leaf blower when horses are in the barn at all is really not ideal for their lungs. If you have mares that have heaves, it's one of my primary recommendations for managing heaves as well is to avoid that, get them out of the barn as much as possible. And also when your barn is being cleaned, even just cleaning stalls, especially if it's dusty straw, you're mixing everything up. So yeah, air quality is really important. Having a well-ventilated barn, all those things can really help.
How quickly, if you have a foal that has umbilical infection, how quickly a newborn foal with an umbilical infection will go from that to infected in a joint?
Sure thing. I think that to put an explicit number on that is hard. I think it's going to depend on the bacterial load, depending on the degree of infection and how much of that is in the bloodstream, because those aren't always created equally. It can happen pretty quickly though, and it's actually going to happen before there are clinical signs of it happening, because we're not seeing the clinical signs associated with joint ill, which are largely due to inflammation, until bacteria has already seeded in. So it's probably happening as soon as that bacteria moves from the umbilicus into the bloodstream, it's circulating. And because of the vasculature, it's going to seed into the joint lining, then pretty quickly thereafter. But I would say there's probably, I don't know, maybe like a 24 to 48 hour lapse there as to what you're going to see it at minimum. It probably can be longer if say that the umbilical infection is maybe just mild at the beginning and then gets worse, and overall systemic status of the foal, I think, is going to affect that as well. Like there are a lot of variables there. It's not going to be immediate though. If you're noticing an umbilical infection at the same time you're noticing a joint infection, it's likely that umbilical infection has been happening for longer than that.
And they can go from a lameness with no swelling and no temperature to deathly ill.
Yes.
In like 48 hours.
Correct. Yep. Yes, that is what foals do, unfortunately, because if the bacteria is in one place, it's likely in the other places. And depending on the type of bacteria and how many toxins are being released by that bacteria that dictates how much inflammation is being caused in all of these different body systems.
And we have that debate a lot when we have a foal come in with a septic joint and an umbilical infection. When do we need to take the umbilical out surgically? And if so, when? Do we do it right away because we're afraid that it's going to seed additional joints? Or do we treat them with antibiotics, ideally based on cultures, and see if the umbilical infection can resolve without surgery?
We have another online question, and I apologize to the person who wrote it. I may summarize this incorrectly. The general question is, does the mare who gets bred back after foaling keep a saggier udder than the mare who is not bred back? Is the age of the mare a factor? My vet was sent pictures, but was not concerned. However, I would like a little bit more info about this.
I would say that you definitely can tell the difference between a maiden udder and a mare that has had foals before. So yeah, I would say there's some enlargement and changes there. If you have any.
I agree. I mean, generally, like every time that a mare is pregnant and has mammary gland development, it's going to not bounce back quite to the same size it originally was. But in terms of like, if you give a mare a year off, is that extra time going to change her udder? I don't know that it will.
I have another online question. How close to delivery should you worm a pregnant mare? What wormer do you recommend? Let's start with that one. It's a two-parter.
Okay. Go ahead. Do you want me to answer?
I'll start with this one. So the question's about deworming pregnant mares. What I usually tell people, all of the dewormers, commercial dewormers that are on the market have been labeled safe for pregnant mares. And so ideally, the mare is going to be on a targeted deworming program based on her fecal egg count, rather than just a blanket. We do this however often. I think it's maybe going out of fashion now, but it was definitely in vogue to treat mares with, or to deworm mares with ivermectin at the time of foaling. I think we've moved a lot more to just using fecal egg counts to do more strategic deworming overall. And as long as we're using those commercial dewormers that are safe for pregnant mares, I don't necessarily worry too much about where in pregnancy they are when we do that.
The second part of that one is, I have heard you can give full tubes of Panacur, I think I'm saying that right, to foals at first worming. What are your feelings?
So the question was about giving a full tube of Panacur at their first worming. So I wouldn't think of it as a full tube. You can give a 10 milligram per kilogram dose, which is a double dose if you're using a standard size tube of Panacure. If you look at a tube from a Panacure Power Pack, there are two sets of numbers. One is in red and one is in black, and I can never for the life of me remember which is which, but one is 5 milligrams and one is 10 milligrams per kilogram. So that 10 milligram, the higher dose, is the dose that will kill the larva of ascarids. So that is absolutely safe to do for foals. And we should be trying to kill that stage of ascarids. Full deworming protocols in general should also really be based on your farm and doing fecals on foals and trying to identify if you have any resistance on your farm to choose what products you're using. Resistance in dewormers is getting to be a huge problem. We are out of products. There are no more drugs. There are no new drugs in the pipeline. And so it's really important to know, think of your farm as a little worm ecosystem. It's not so much that individual horse that you are looking at. You're trying to identify what products are going to work on your farm. And that requires doing a lot of fecals on groups of foals.
I missed some of the breeding part of things early this morning. I'm sorry. I breed warm bloods. We use frozen semen about half of our breedings, and your success rate with frozen is really not great, and you can get lucky. But I had read there was a new semen extender developed in Australia that was targeted for show dogs originally, and they had found under testing that it could keep fresh semen viable. The aim was to reduce inflammation that was caused by foreign proteins, in semen extenders, and they were successful. And in their tests, they had fresh semen that was viable after 2 weeks, which would be a game changer for breeding, even, shipping stuff from Europe to here. Is anybody using it?
So the last time I heard, they were trying to get it approved, and they haven't yet. And I've been checking their website every year at the beginning of every season, hoping that it's gonna happen, but it's not here yet.
Okay,
Unfortunately.
I was wondering because I was like, if you could do that,
Yeah,
why wouldn't
it would
you
be
do that?
awesome.
So yeah, okay. We'll send up a bulletin or something.
So the question is about using Nexium for ulcers. And if I've heard of doing that, yes. Nexium is the same category of medication as pantoprazole and omeprazole. And the problem with horses is the way they digest things. And so the reason GastroGuard is expensive is because of the carrier that is with the omeprazole. And that is what allows horses to absorb it. So any other form of omeprazole, you can go buy omeprazole off the shelf and give it to your horse, but they won't absorb it and it won't be as effective. So it's the same situation with Nexium as well. Gas-X, you can use it. It's not as effective as if you're talking about treating ulcers, there's nothing that beats GastroGuard.
I meant like for bloating.
For bloat, yeah, I haven't had great success with it. So we use Buscopan a lot more now that we have it.
Another online question is, do you recommend umbilical clamps, and do the clamps hold bacteria that can cause infection?
I recommend not putting anything on the umbilicus unless you need to. So ideally, the umbilicus tears naturally, or you tear it in a way that is more natural. Do not cut it. Please do not cut it. That it is meant to tear, and that allows those vessels to contract, and it allows the best chance for it sealing up and not getting an infection. And then dipping it, as Dr. Gosselin said this morning, I'm also a huge fan of dipping the umbilicus. The only reason I will put a clamp on is if they're really bleeding excessively. And I like to put the clamp on not too close to the body wall, because you don't want it to necrose off too close to the body wall, because then it's more likely to stay open and you'll have a patent urachus. And I like to, if I put a clamp on, I try to take it off 24 hours later when everything is clotted and sealed up so that it's not there as a nidus for infection. We use it, our dystocias and C-sections especially, like we do clamp those routinely, but sometimes we'll clamp them way far down the umbilicus and then actually go back and tear it. Dr. Pash and I are a little obsessed with tearing it the right way. But and part of that is because the sick foals that I have in the clinic are much more likely to develop a patent urachus and sometimes a secondary infection, because if they're recumbent for a long period of time, they're lying on their umbilicus, which obviously they shouldn't be doing naturally, then it's much more likely to become infected.
So when you're
Yeah.
tearing an umbilicus,
Yeah.
you sort of put your hand against the abdomen.
Yeah, I like to put my fist against the abdomen. So I have like my hand's not that big, but so I have like a fist distance between where I'm gonna tear it and the body wall. Does that make sense? So I like hold it like this and then, yeah. Yeah. So we do, and then we kind of.
Yeah, and you can sort of strip
Strip
it
it.
from the other side.
Or just kind of held my hand, like not grab the umbilicus, but just hold against the abdomen.
Yeah, it might be more appropriate the size of your hand versus mine. But anything, so I just want to avoid tearing it too close to the body wall. Yeah. And we do see that sometimes, sometimes the fold just jump up and it snaps in the wrong place, basically. So
You can usually see a little spot where it's meant to tear, where it's like, it's kind of narrower and whitish, and it's the natural breathing spot, I guess. Yeah. Tear, yeah, exactly. Tear along dotted line.
Is iodine still the recommended for dip?
yeah, I have no problem with iodine as long as I'm not a fan of tincture of iodine, because that tends to be really irritating. And if you get it anywhere other than the umbilicus, which is of course very easy to do in a healthy foal that's bouncing around, I've seen so many foals that they use tincture of iodine and they get this massive plaque of edema all around the umbilicus. And then they end up being more prone to infection because it's so irritated. So, but I do like betadine is more drying. The other thing that we use a lot is dilute chlorhexidine, which isn't as drying as betadine, but it does work better in the face of organic material. So I'm sort of 50-50 on them. We use chlorhex routinely, dilute chlorhex in the clinic, unless they get too damp and then I switch.